Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuh. A very good morning to all the doctors and our paramedics from all over the world who have come online for the most awaited virtual conference of the year, the 6th annual Dubai Pediatric Club Conference, organized by Dubai Pediatric Club in affiliation with New Country Healthcare, Johnson & Johnson and NMC Specialty Hospital, Dubai. Myself, Tawfiq Ali, Country Business Manager of New Country Healthcare. Every year, DPC and NCH organizes the DPC annual conferences. And this year, due to unprecedented situation, we have decided to go virtual, which has given an advantage for doctors all over the world to attend our flagship conference. Before we start, I would like to give a few housekeeping tips. Once you log in, you will be brought to the lobby. At the lobby, you can download the conference brochure, agenda, and speaker profiles. You can click on auditorium, exhibition area, and networking launch to access the respective sites. At the networking launch, you can chat with your peers who are online. At the auditorium, you can watch the conference live. Please click on the Q&A tab on right-hand top side of the virtual auditorium and enter your email and name only once in the beginning, enabling you to participate in the Q&A and polls as well. This you have to do only once, no need to do every time. During the day, throughout the sessions, we will be having many polls and quizzes which carries valuable prizes if you participate. At the exhibition area, you can see 12 different company stalls, and please visit all the booths where you can watch the company video, download brochures, have a video call with the company representative and chat as well. In all the booths, you will find a raffle question on the right-hand top side. Please answer all the questions at the booths, which will enter you into raffle draw. This is important in order to enter yourself in the raffle draw. There will be 3 draws, one at the end of morning session and 2 at the end of afternoon session. This program is accredited with CME points, and the CME point depends on the time you keep yourself logged on during the day. I will explain at the end of the day how to claim your CME certificates. And to proceed further, I would like to invite Dr. Sohrab to take over the program. Dr. Sohrab Tomarai is the president of Dubai Pediatric Club and is working as a senior specialist pediatrician at NMC Specialty Hospital, Dubai. Before Dr. Sohrab takes over, I would like to play the national anthem of UAE in respect of this great, wonderful country. Here we go. And Dr. Sohrab, please come online once the anthem finishes.
Good morning, ladies and gentlemen. On behalf of the organizing committee of the 6th annual Dubai Pediatric Club Conference, I would like to welcome all viewers from all over the world to this virtual conference. This conference has been organized in collaboration with NMC Specialty Hospital Dubai. I would like to thank the management of the hospital, Dr. Kamran Taktis, Dr. Manoj Varma, and a special thanks goes to Dr. Vamsha Shetty from the organizing team for their help and cooperation. I would like to thank the chief guest, Mr. Michael Davis, the Honorable CEO of NMC Healthcare, for accepting our invitation to deliver the inaugural speech. This conference has been sponsored by New Country Health, Vitabiotic, and Johnson & Johnson companies. I would like to thank Mr. Tawfiq Ali, the country manager of Vitabiotics, and Mr. Danny Yahya, the Gulf manager of Johnson & Johnson. All 6 consecutive annual DPC conferences since 2015 have been organized by Mr. Tawfiq Ali. We are grateful to him. A special thanks goes to respected faculty member, all speakers, moderators, panelists, chairpersons of this conference. I would like to thank the members of the organizing committee, especially Dr. Kalpana Sengupta, the secretary of the club, also Dr. Joshi, Dr. Amir, Dr. Jundi, Dr. Diari, Dr. Rafia, Dr. Bandari, Dr. Bushra Azam, and Dr. Khalid for their help and support. At the end of this conference, we will felicitate the senior members of the club who have helped us, and in a special ceremony, we will felicitate them. Well, now on behalf of the organizing committee of the 6th Annual Virtual Dubai Pediatric Club Conference, it gives me a great pleasure to introduce our honorable chief guest, Mr. Michael Davis, the Chief Executive Officer of the NMC Healthcare. Sir, I would like to thank you for accepting our invitation. We are proud and honored to have you with us today, and I would like to request you to deliver your inaugural speech. Thank you very much, sir.
Hello, everyone. My name is Michael Davis, and I'm the CEO of NMC Healthcare. I'd like to welcome you on behalf of everyone at NMC to the 6th Annual Dubai Pediatric Club Conference. This year is especially exciting for us as the President and the Secretary, respectfully, are both from NMC Specialty Hospital in Al Nada. And we're so proud of Dr. Sarab and Dr. Kalpana and all of our pediatricians and the work that they do across the NMC group. As an organization, NMC Healthcare sees almost 4,000 pediatric patients per day across the Middle East. Pediatrics is an extremely important part of our portfolio, and we think that every effort should be made to promote and enhance the service that we provide to pediatric patients across the group and across the UAE. The Dubai Pediatric Club was started over 25 years ago, and there are now over 1,000 physicians that utilize the club. And there are monthly clinical groups and discussions that take place, and every effort is made, I think, to continue to improve the way that we treat children. Even in a global pandemic, I think that nothing can dampen the spirit of this type of a conference. And it's exciting for me to see people from all different communities and from different healthcare groups coming together really with the sole focus of being the patient. At the corporate office, people like myself who aren't seeing patients day to day, we realize that every decision that we make daily does trickle back down to the point of care. And while we as administrators are out doing our thing and trying to ensure that healthcare companies are healthy and well run, you guys every day are going to work and caring for patients at the point of care and improving their lives. And if it wasn't for each and every one of you and the physicians and people such as myself and the other healthcare leaders that head the organizations in the UAE would have no job to do. So the real work and the important work is done by people such as yourself. And conferences like this, where you challenge one another and learn from one another and seek ways to better improve care and outcomes, are very, very important. And the pandemic's not going to dampen the spirit. I'm sure that there'll be a lot of spirited discussion over the course of the day today on how to improve outcomes, how to better care for our patients. And it's just an honor for me to even be able to speak to you and to wish each and every one of you a very, very good conference. So on behalf of everyone at NMC Specialty Hospital, Dr. Kamran and his entire team, on behalf of the leadership of the Dubai Pediatric Club, I just want to thank every single one of you for your effort and for your time, and I want to wish you the best of conference. So from this point on, the conference is open, and I wish you the best day. Thank you so much.
Thank you very much, sir. Thank you very much, sir, for your kind words. We are honored. Now, we will start our academic session. Today morning, we have 2 sessions. In each session, we have 2 panels. First panel is neonatology panel, and the second panel will be gastroenterology and pathology panel. In our second session, we have 2 panels again, pediatric surgery panel and pediatric neurology. So I would like to introduce the chairpersons of the first panel, neonatology panel, 2 of the senior most pediatricians in Dubai, Dr. Rajinder Joshi, the past president of Dubai Pediatric Club, senior specialist pediatrician at Prime Hospital, and Dr. Srinivas Bandari, senior specialist pediatrician at NMC Specialty Hospital Dubai and member of the Dubai Pediatric Club. Now I would like to request Dr. Bandari to introduce Dr. Monica, the moderator of the first session neonatology panel. Dr. Bandari, please.
Thank you, Dr. Saurabh. Respected Michael Davis, Dr. Saurabh, Dubai Pediatric Club, for giving me an opportunity to chair the session. Under the presidency of Dr. Saurabh, the 6th annual conference of Dubai Pediatric Club is at international standards. More than 1,000 members from India and other parts of the country have registered for the webinar. I'm wishing all the success in ongoing of this conference. To start with, it's a privilege to introduce the first speaker, Dr. Monica. Attractive name. Her parents identified her as Jam and called her Monica. Dubai Pediatric Club identified her as well-known neonatologist and called her to enlighten the audience. Proud that she is from Rajasthan, India. The basic medical education, MBBS from Jodhpur, Rajasthan, India. MD Pediatrics from prestigious PGI, Chandigarh, India. DM Neonatology from prestigious Indian Institute of Science, Delhi. She has fellowship from Royal College of Pediatrics and Child Health, UK. Diploma in Neonatology, Southampton University, UK. Monica is a high academician. She is the President-elect IAP Neonatology, Secretary National Neonatology Forum. She has published and she has publication in national and international journals. She has authored the chapter in Protocol, Book of Neonatology IAP, editor of Journal of Child Health, and editor of Al Jahara Medical Journal. She has started fellowships in neonatology affiliated to IAP, and so on. Sorry, the time is short. With this introduction, I request Dr. Monica to proceed with the deliberations.
Thank you, Dr. Bhandari, for elaborate introduction. So, good morning, everybody, and thanks a lot for giving us opportunity in this prestigious conference, Dr. Saurabh, Dr. Kalpana, and the entire team. So, we are the opening batsmen, and I hope we'll keep everybody awake throughout. So we'll try to make it as practical as possible, and I would like to introduce our panelists. I don't know why I'm not. So the first panelist is Dr. Zahir. He's a good friend and consultant neonatologist in City Hospital. Dr. Nishad is another good friend and consultant neonatologist in Zulekha Hospital. Dr. Ashraf is consultant neonatologist in Sheikh Khalifa Amal Quain. So I think we need to keep see that everyone is there and awake. We will start with a poll. So a pulse oximeter screening, can you put the poll on? The pulse oximeter screening can detect all the congenital heart disease except truncus arteriosus, coarctation of aorta, tetralogy of Fallot, hyperplastic left heart syndrome. Is the poll on?
Yes, ma'am.
Because I can't see the poll. I don't know if I can't see the poll, so I don't know if people can see or not.
The audience can see it.
No, because I'm in that audience thing, I can't see the poll. Anyway, so I will move forward because I can't see the poll, and the answer, if everyone has answered and if they could see the poll, the answer to this is coarctation of aorta. So let's move to the case. Let's see how did we arrive to the this kind of scenario. So we go to a case. We have a day 2 baby, full term, who's got no anomaly scan. Birth weight was 3.2, born by normal vaginal delivery, had a normal Apgar, and was just with the mom feeding well. And a routine pulse oximetry was done on day 2. The SATs were lower limb 86, right upper limb 88, left upper limb 86, and lower limb pulsations were well felt. Baby has no respiratory distress at all. So what is the ideal time, Dr. Nishad, to routinely do the pulse oximetry screening for these newborns?
Yeah, the ideal time is 24 hours after birth. In case of early discharge, which is before 24 hours, the screening has to be done just before discharge to reduce the false positive rates.
Okay. So what are the diseases that are routinely detected by the screening?
Yeah, so we have the primary targets and the secondary targets. The primary targets are the major cyanotic congenital heart disease like TGA, PVC, truncus arteriosus, tricuspid atresia, tetralogy of Fallot. And the secondary targets of critical coarctation of aorta, hypoplastic aorta syndrome. Other than congenital heart disease, congenital pneumonia, PPHN, and sepsis can also be picked up with the screen. It cannot detect, however, left to right shunt like simple ASD, VSD, and PDA, and this should be explained to the parents also.
Yeah, this is very important point that you should explain this to the parent, because the parent, once you do the newborn screening and you get something later on, the parent will come back to you to say that, how come? Yeah, this is very important. So are there other conditions which can be picked up by this pulse oximetry screening, Dr. Nishad?
Yeah, apart from congenital heart disease, pneumonia, pulmonary hypertension, and a few cases of early onset sepsis can also be picked up by the heart screen.
Yeah, so that's good. So we can act other things as well. So how do you interpret them?
So
like this baby, what do you interpret?
So this baby is an asymptomatic neonate which was screened on day 2. The saturation on the right upper limb was 88%, and the left upper limb was 86, and left lower limb 86%. So we'll categorize this baby as a test fail because the saturation of less than or equal to 94% in either right hand or foot, or if the difference is more than 4%. So in this baby, the saturation is less than 89%, which itself indicates it's a test fail. So this baby has failed the pulse oximetry screen test. Next slide, please.
Okay, so this baby, does it require now referral according to you, Dr. Nishad? Or what would you do with this baby?
Yeah, so any baby who has failed the pulse oximetry screen should be evaluated in detail. Basics should be followed first. We have to do a detailed clinical examination, look for the murmur, admit the baby in the ICU, do the forelimb blood pressure. So this baby has to be evaluated by a pediatric cardiologist. However, if you don't have the service immediately, you have to follow these things. Do a detailed clinical evaluation, admit the baby to an ICU, start oxygen, do a chest X-ray, ECG, call for a pediatric cardiologist, do an echo, and all this has to be explained to the parents.
Yeah, thank you very much. So yeah, that should be the goal. Now, if we have a antenatal normal scan, Dr. Zahir, still you will go for a pulse oximetry, like in a healthy child?
Yes, but it depends really on your hospital and organization and on your region policy, because the pulse oximetry screening is still not universally applied to every single institution throughout the world. I mean, if you are talking countries, the UK, for example, does not have a universal oxygen saturation screening program. There is a very recent survey been published only last month showing that only about 60% of neonatal units and maternity wards or postnatal wards in the UK are doing universal oxygen saturation screening. So I think overall the discussion is still ongoing about universal oxygen saturation screening for babies. However, you can see from this slide that there is a diagnosis gap or diagnostic gap that has been actually covered partly by implementing overall or universal pulse oximetry. So the risk of missing serious congenital heart diseases, early onset sepsis is a very important thing to highlight as well. This diagnostic gap, as you can see from the bar on your right-hand side, if you look at this slide, it shows that the diagnostic gap is obviously the red one is smaller if you compare it with people who are not using oxygen saturation as a tool to detect congenital heart disease and other problems. So I would say, I will go for oxygen saturation screening for babies in my institution, and I will be looking for congenital heart diseases as well as other important things like early onset sepsis and pneumonias and others. Thank you.
Yeah, so the law of the land where we are, it's also recommending to use a pulse oximeter screening for all the babies, and it's doing no harm. So, and it's a very easy method, which I think if someone has concern, Nishad, can you tell me how exactly it is done and how do you interpret it?
The screening is done usually after 24 hours. If discharging early, it is done early. The saturation of the right hand, which is the preductal, and either of the foot, postductal saturation is measured either simultaneously or one after other. And the recording should be done for at least 2 minutes. In this diagram, I have shown the place where the probe has to be attached in the right hand and the foot. Next slide. So this is a new algorithm which has been updated in 2020. So you have to measure the pulse oximetry on the right hand and 1 foot around 24 hours of age. Now, if the saturation is more than 95% or more in right hand and foot, both right hand and foot, and the difference is 3% or less, it is a pass test. You do not repeat the screen and you provide normal newborn care. Now, if the saturation is less than or equal to 89% in either of the foot, it is either right hand or foot, it is a failed test. Here, we do not repeat the screening like in the older algorithm. We repeat it after one hour. So we do not repeat the screening in this and refer for immediate assessment. However, if the saturations are borderline between 90 to 94% in either right hand or foot, or the difference of 4% or more, then you repeat the pulse oximetry screen after 1 hour. So in the second measurement, if the saturation is more than 95% and difference is less than 3% between the two limbs, then it's a pass. But if the saturation here, it is less than or equal to 94%, then it is a failed test. So you have to note the difference between the first test and the second test. The first test, if it is below 89%, it's a direct fail. There's no repeat test. And in the second test, if it is below 94%, it is fail.
Okay, so there is a difference, and which everyone should be knowing how is it different, and it's become more easier and more simpler actually. Yeah. So let's move to another case. We have a full-term baby who was paying with no respiratory distress. Saturations in the both upper and the lower limb was 97%, and the blood pressure was fine. All the peripheral pulses were well felt. The general, our GP went to examine the baby, and he called us to say that, oh, there is a grade 3 murmur on the left lower sternal border. And when I asked, okay, for you examine fully, he gave us a clue that there is no hepatosplenomegaly. Baby is absolutely fine, no dysmorphism. So Dr. Ashraf, now when registrars call you, and then what will you do, and how will you clinically evaluate such baby, and when would you call a cardiologist in this situation?
Yeah, good morning, everyone. This is a very common case scenario that we come across in all the pediatricians in all over the world come across this case, at least 1 to 2 cases per month, depending upon the number of deliveries in their hospital, as the incidence of congenital heart disease roughly around 0.8 percentage. So you may get 1 to 2 cases per month. So this is a well-looking child with a cardiac murmur. So how do you investigate further? So the most important thing that you need to do the history, a thorough history, like whether the mother has taken any medication during pregnancy, like anti-epileptic or antidepressant or SSRI, or if the mother had any viral infection during pregnancy, or you need to inquire about the diabetic status during pregnancy. And also, most often we forget to ask these questions like family history of any congenital heart disease or sudden death early in life. So then you come to the physical examination, you do the examination of the cardiovascular system, you do the examination, you do the pulse oximetry in the upper limb and lower limb. You also check the blood pressure, which is very important in the upper limb and lower limb, and look for the cardiac murmur. Depending upon the cardiac murmur, you can classify whether it is it's a murmur, it's a benign condition or a congenital heart disease. So my take-home message in this is that even if you do the physical examination and if you find a cardiac murmur, and the baby is very well looking, that doesn't rule out any congenital heart disease. So because the serious congenital heart disease can present with the murmur alone. On the other hand, the congenital cardiac disease can also present without murmur with the catastrophic presentation. So when you come to these kind of cases, if the baby is well looking, no signs of cardiac failure, the pulses are normal, the saturation is normal, second heart sound is normal, and the murmur is only of grade 2 with the, it's not a harsh in quality, then you can qualify it as a innocent murmur, and then you can wait for doing echo at least 2 weeks, or you can especially this is a common case scenario that we come across because we don't have many cardiologists in UAE. In the second case scenario is you are as in this case murmur of grade 3 intensity, and if you can look for any dysmorphic facies, you can look for abnormal S2 or the murmur starting with S1 or RV impulse or epigastric impulse. In this case, the chance of congenital heart disease is very likely. Then you need to call for the cardiologist as early as possible. And then the third case scenario is a baby is presenting with the cardiac failure or shock, and pre and post-rectal saturation difference of more than 4%, or the baby is coming with a murmur with a weak femoral pulse or absent femoral pulse. In that case, you need to call for the cardiologist urgently. You need to admit this patient. So,
given messages, and I think the pulse oximetry should be joined with your cardiac examination. That's the take-home message. We cannot rely on just one single thing. In such scenarios, which usually we get, Dr. Zahir, when do you really start prostaglandin infusion? And especially when you don't have echo facility, what do you do?
Of course, I think if you do not have an echo facility, then I think the clinical suspicion obviously will be your only tool. And then if you have significant cyanosis that is visible or documented on oxygen saturation oximeter, then I think the safest thing to do is to start prostaglandin infusion until confirmation or exclusion of such a duct-dependent lesion could be done. So basically, prostaglandin are used as an infusion to keep the duct opened until a duct-dependent lesion is either proved or excluded. If you have an antenatal diagnosis, which is obviously nowadays is becoming increasingly possible, then if you have a strong suspicion antenatally of left ventricular or right ventricular outlet obstruction conditions, or there is a suspicion of transposition of great arteries, then obviously the case for starting prostaglandin infusion is even stronger.
Yeah. So, I mean, we can start anytime, and if the baby doesn't improve, we can stop and then, call the cardiologist to know exactly what's going on. Yeah.
Of course, of course.
Okay, so let's move to the third case. It's again a full-term baby who was born by vaginal delivery, but was a very difficult delivery. So vacuum was put, forceps applied, and there was thick meconium stained amniotic fluid, and baby had to be resuscitated with IPPV and cardiac and adrenaline, and had a very low Apgar 355 at 1, 5, and 10 minutes. Transferred to NICU at 1 hour of age after stabilization. And when we saw at admission, baby had really poor respiratory efforts, tonic posturing, seizures were there, pale, poor peripheral pulses, and the blood pressure was quite low in both the upper and the lower limb. SATs were 98 in the upper limb, and the lower limb was 85, and the blood pH was 7.1 with -16 of base deficit. Now, Dr. Zahir, this kind of baby you must be coming across. How do you stabilize this baby in the first go?
Yes, this is a scenario, obviously, that all of us can be in at any time, day and night. And I think basically the stabilization will start as usual with the breathing, so that this baby has, if the baby has no or very weak respiratory effort, will be intubated and ventilated. And the aim is always to keep the oxygen up and to obviously keep the carbon dioxide within the range of 35 to 50 millimeter mercury. Cardiovascular system comes obviously equally important. You need to secure central lines, you run your basic blood test results, and you need to monitor the blood pressure, of course. You may need to start a fluid bolus to support initial cardiovascular status. Your assessment of neurological status is important, and clinical assessment is important because you'll have to make decisions based on that later. Head ultrasound scan, easier to do as quickly as possible. Later we'll talk about MRI, but this is something that you have to keep in mind, but later, only later. If these babies show any signs of neurological disturbances in the form of seizures, the first line recommended anticonvulsant will be phenobarbital, but the debate becomes more intense when it comes to the second line, but this is basically down to your unit guidelines. Nowadays, newer anticonvulsants are coming to the surface, I mean, people are moving slightly away from phenytoin to replace it with newer anticonvulsants, and they are becoming even standard for some units. Antibiotics, if there is any risk factor for infection, remember, if you are using gentamicin, because of its potential nephrotoxic effect in such particular babies, then you need to check the pre-dose level before the second instead of the third dose. It is advisable to be minimum with your fluids infusion, as you never know what's going to happen. So starting with 40 mL per kilo is a reasonable starting point. If you are having any problems with the blood glucose level, then you may consider higher glucose infusions. And obviously you have by now a central line, presumably, which will allow you to go higher. Sedation is important if you are really having issues, especially with ventilation. But it's not, to be honest, it's not only sedation, but it's also pain and discomfort. If you are, we will talk about the obviously subsequent management, and pain and discomfort should be managed very well. Muscle relaxation should be avoided if you are worried about blood pressure until later, when you are in a good support of blood pressure. Do not forget to talk to parents. This is very important. A member of the team should be given the task, the important task of, in the midst of all this busy time, to talk to the parents and to update them, and not to kind of, mention much about the outcomes and the risks, but it's very important to be clear upfront and to be very, very balanced with your views on this.
Okay, so very well managed. I'm sure the baby will be doing well, but Nishad, would you do something more? Would you do some in this baby therapeutic hypothermia? Would you consider?
So in this baby with severe asphyxia, therapeutic hypothermia is the treatment of choice and the standard of care now. So we have the cooling criteria as described by Toby et al. We have the criteria A and B. We'll see whether this baby will fit into that. So any baby with more than 36 weeks gestation admitted to the NICU with one of the following. So this baby was a term baby. Apgar score of less than 5 at 10 minutes after birth. Our baby's Apgar score was 5. Continued need for resuscitation, including endotracheal intubation and chest compression at 10 minutes of birth. So this baby received positive pressure ventilation. Cot pH less than 7 at 60 minutes of birth. In our case, it was 7.19. But if you see the base deficit more than or equal to 16. So in our case, it was minus 16. So one of the following our baby satisfied the criteria. Criteria B, seizures or moderate to severe encephalopathy. So if there are seizures, then definitely it is considered. If there are no seizures, then we have to consider the altered state of consciousness, like a reduced response to stimulation, abnormal tone, generally hypotonia, and preemptive reflexes are absent. So if these criteria are satisfied, then our baby will definitely need cooling.
So your baby needs cooling, yeah? Yeah, okay. So now this baby started on cooling, was well ventilated. However, even on the ventilation of 28/5 and rate of 60, FiO2 went up to 80, 100. The post-structural saturations remained 80% and the BP was like 30. Now, what could be the cause of shock in this baby, Dr. Zahir?
I think you go back to the really the ABCs, and you start from the basics. You need to make sure that a baby who's in the ventilator, who is really poorly oxygenated and hypotensive as well. I mean, as the underlying cause, I will think of sepsis. I will think of poor cardiac functionality because of the hypoxia and acidosis that this baby has been through, and also the abnormal muscle tone, which may contribute to hypotension as well. So these are the underlying causes, but obviously, technically, as a neonatologist, you have to revise and go through all the possibilities, including ventilation and pneumothorax and other things.
Thank you. So let's go for this poll to keep the people awake, and I hope this poll opens now. So of the following medications listed below, can you open the poll, please? Which agents have the potential to increase cardiac contractility while causing the heart rate to decrease? Is it dopamine and dobutamine, dopamine and epinephrine, epinephrine and norepinephrine, milrinone and epinephrine, norepinephrine and dopamine? Are the polls on?
Yes, ma'am.
Because I can't see polls. I can't see, but anyway, the answer is epinephrine and norepinephrine. So let's move on to this case now. What will you do, Dr. Ashraf? Will you give a bolus? Will you start dopamine? Would you start dobutamine? I think every day we are asking this question to ourselves, what to do now. Can you elaborate and make us more wiser?
Yeah, I mean, as Dr. Zahir mentioned, the cause of the shock could be various in this particular case. It could be because of the the baby definitely has hypotension, because the mean blood pressure is less than 40, and the baby has prolonged capillary refill time. So there is no standard definition for the hypotension. So, but we need to treat the hypotension numerical value, because we don't have the evidence that not treating hypertension is going to improve the outcome. So in this particular case, because it could be because of the problem, maybe because of hypovolemia or capillary leak, or maybe because of cardiac poor cardiac function, I would start with volume expansion because this case is a HIE. I wouldn't go higher fluid, so I will give with start with the 10 ml per kg of normal saline bolus and look for the blood pressure improvement. If there is no improvement and there is, blood pressure is still low, then I would go for, inotropes. So because the most common reason for hypertension in perinatal asphyxia is myocardial contractility or myocardial contractility, I would go for dobutamine in this case. And after increasing the dose of dobutamine, if there is no response, I would start dopamine. But thinking that dobutamine may not increase the blood pressure, even though it increases the cardiac contractility, may not increase the blood pressure as such. So it will treat the cause, and if you treat the cause, subsequently the blood pressure will go up.
So we should be knowing what we are why the shock is, and our inotropes will be directed to that. Very well explained, Dr. Ashraf. So as this baby is having a issue about, if we see that there is an issue about the upper limb and lower limb SATs are low, the baby is requiring very high oxygen and ventilator requirement, there was a meconium stained amniotic fluid. So there is something more which we are dealing with, and I'm thinking about PPHN. So what would be the drugs which is currently, please open the poll, which is currently not recommended in PPHN? Inhaled nitric oxide, sildenafil, milrinone, and soda bicarb. So can everyone see the poll? Somehow I'm not able to see, but I will just give the answer. So definitely now in this era, soda bicarb would be not recommended in PPHN, though we want that the pH should be higher, but not with the soda bicarb. So this deterioration which we saw, that the baby is requiring so much of ventilator setting and difference in the SATs. So how will you manage further now, Dr. Ashraf?
So in this case, you can see the maximal ventilator support of babies on PIP of 28 with 100% oxygen, but the saturation, especially in the postrectal, is 80, and the preductal saturation, pre and postrectal saturation difference is more than 10%. So we should think about the PPHN as a cause, and you should call for a cardiologist to do the echo. Meanwhile, you can start treatment. Treatment of the PPHN is basically the treatment of the cause. So if you treat the cause, and if you the PPHN is also going to get better, you maintain adequate systemic blood pressure by giving the inotropes, as I mentioned before, and the oxygen, as you are giving maximal oxymal supplementation, but 100% oxygen for long period of time is also going to cause free radical damage. You need to keep saturation around 90 to 95 and PO2 around 60, not more than that. And then you should think about the considering vasodilators. And also, you avoid hypoxia, acidosis, hypercarbia, and you need to sedate the baby, as Zahir mentioned before. This can, reduce the pulmonary pressure. If the hematocrit seems to be higher, you need to do some intervention to reduce it, because high hematocrit can also elevate the pulmonary pressure. And then, of course, you need to, because it's a meconium aspiration syndrome, you need to ventilate the lung very well. So you have to switch to high frequency ventilation by this time. If these measures do not, improve the PPHN, then you look for the oxygenation index, which is the mean airway pressure multiplied by FiO2 divided by PaO2. And then if that oxygenation index is more than 25, then you should consider pulmonary vasodilator as inhaled nitric oxide is the treatment choice. So
so you will consider nitric oxide or sildenafil in this scenario, Dr. Ashraf?
In this case, definitely I will consider nitric oxide, because it's a selective pulmonary vasodilator. It doesn't have any systemic vasodilator effect. Sildenafil, on the other hand, is not proven to be a primary treatment modality for pulmonary hypertension. Also, it causes systemic hypotension. So this baby already has systemic hypotension, so it may aggravate the condition. So you start nitric oxide, that's a 20 rule, like 20, start with the 20 parts per million and look for the PaO2 to response of more than 20. And then, you continue the response. If there is no response, and then you should think of myocardial, poor cardiac contractility, or, the lungs are not, very well expanded, or you treat the other condition that I already mentioned, like hypotension, fluid loss, all those conditions, you optimize those treatment. And if the patient is responding, you can gradually wean from the nitric oxide.
Can you just tell us how do you wean? Like, because everyone knows how to put, and then they don't know how to come back. So can you tell how to wean off?
Yeah, once you start nitric oxide, monitor for the PaO2 and saturation. PaO2 keep at 60 and saturation 90 to 95. And the first thing that you need to do is wean the oxygen. You need to wean down the oxygen to 60%. Then only you start to touch, the nitric oxide and the ventilatory settings. So once you reach 60% of the FiO2, then you can wean down by 5 parts per million every 4 hours. And once you reach 5 parts per million of nitric oxide, then you can wean by 1 parts per million every 4 hours. And you gradually stop, because gradual tapering is important, because it can cause rebound PPHN. So it should be gradually weaned down, especially once you reach at 5 parts per million.
Yeah, thank you, Dr. Ashraf. So rule to start is 20-20-20 and rule to wean off 60-60-60. Please remember this, so it'll be easier. So this baby was started on dobutamine and was reached to the maximum of dobutamine, but did not improve. So we put on dopamine, and ventilation was optimized. Nitric oxide was started. So FiO2 requirement reduced to 30% in next 6 hours. We did a job well. Everything together, 3 of us could manage the baby well, I think. So whenever we have a baby with asphyxia, we all know that cardiac contractility is a common problem, and systemic blood pressure should be targeted, but not like suprasystemic should not be targeted, and nitric oxide to be given when PA pressure is suprasystolic. Next, move to this case 4. Now, this is a common scenario nowadays when your obstetric colleague calls you that mom has come in the labor pain, bleeding in 23 weeks of gestation. What would you tell her, Dr. Zahir? Quickly, can you tell us, what will you tell the gynecologist?
Well, thank you. This is obviously a very sensitive situation that all of us could be in at any point. I think the debate is still on, but this baby is, remember, this is 23-weeker whose mother presented with bleeding, so there is an imminent delivery happening. The current approach is really mainly driven by the British Association of Perinatal Medicine, a very, very useful document that's been published recently, only the end of 2019. So to summarize the approach, I would say this approach should be a risk-based approach, and the risk is divided into 2. One is basically gestation-based risk. So this is a 23-weeker. This is classed as a high risk, very extremely or high risk baby situation. The resuscitation, when I approach this with parents, resuscitation will go ahead. The neonatal team will be there, and then full assessment will be carried out. There are some modified risk factors that should be taken into consideration. And these are including the clinical factors and the fetal factors, if the baby is male, if it's a multiple pregnancy, if there is a abnormality with the finding antenatally. But when you talk to parents, of course, you have to mention the outcomes. So babies in this category, as highlighted from this slide, 1 in 4 of those babies may survive, but with severe disability and impairment. Survival rate is important to mention. We do not have a population-based survival rate here in UAE, but the figures that we have from all over the world are really variable, but we can say at 23 weeks, you'll be talking about, in your best chance, will be 40 to 60%, depending on where you are. This is just a table showing you how this baby arrived at being classified as an extremely high risk baby with a more than 90% risk of mortality or disability. And that is because we estimated the risk by gestation as well as by the modified risk factors. So basically, the neonatal team will attend, will assess, and then will decide. There are situations where you will end up going from being an active care situation to a comfort or palliative care. And in these cases, then the team will back off, but they will still attend. No resuscitation measures, active ones, will be implemented. Parents should be obviously made aware that baby may have some respiratory effort after birth, and these may continue for some hours actually after birth. So people should not be appearing hesitant or reluctant to do things when they have already decided what to do with this baby. There are situations where even if the comfort care is decided to be the main line of action, you may have to revise that with the parents in case the baby will come out in a very, very good shape and showing signs that this baby is resuscitatable and require or deserve a chance of trying. Thank you.
Yeah, so it will all depend on your unit to unit, what is the survival rate and what is the situation of the baby when the baby is born. Yeah. So we have to be very careful on when we get such calls. Let's move to our last case, 26-week, 800-gram baby, LSCS, because of the preeclampsia, incomplete steroids, RDS, and baby intubated in the delivery room. This was the X-ray, and seeing this X-ray, 2 surfactants were given, baby improved steadily, and the X-ray improved to this. The head ultrasound was done, which was normal, and baby could be extubated on day 3 on CPAP, and baby was on TPN plus feed was getting graded up. But on day 4 had a clinical deterioration and the worsening respiratory distress. So what could be the cause of this worsening? Because there is an increased oxygen requirement, off color, tachycardic, blood pressure is 51/24/27, and no murmur. The acidosis is just starting in. So what would be the cause of this worsening? Lactate is 4. Nishad.
Yeah, so we have a list of differential diagnoses to be thought of. These are the common differential diagnoses like sepsis, pneumothorax, pulmonary hemorrhage, cardiac, especially patent ductus arteriosus, and severe IVH. All these can cause acidosis, shock, hypotension. So we have to rule out each and everything. So in this baby, I think we will go to the next slide. So culture started IV antibiotics and gave saline bolus. CRT improved, but baby's distress continued. So baby developed pulmonary hemorrhage. So reintubated and ventilated. The echo showed large PDA.
So why like this baby, there is no murmur, nothing, and why this, from where this PDA came?
Yeah, so it is very important to know there is a median lag time of 2 days before the symptoms appear. Compared to an echo, when we do an echo, the echo can show hemodynamically significant PDA, but the signs like hyperdynamic precordium, bounding pulses, or murmur can appear after 2 days. There is a median lag of 2 days. So we should not rely only on the clinical signs.
So you mean that we should do routinely the echo before extubation to avoid these kind of complications?
No, not necessarily. It should be a case-to-case basis based on the clinical assessment. However, few units are practicing to do echo in a 24-25-weeker baby where the chance of hemodynamically significant PDA is high. But it is a unit policy and it will depend on the case-to-case basis.
But you should have a high suspicion and you should be doing it at early and not like, because these signs will come quite late and then at that time to treat PDA might be a bit late. Yeah. So what would be the clinical reliable signs of PDA, Ashraf, and how would you think if we want to treat this or not?
Yeah, this Nishant has already mentioned a little bit of signs because, in the first couple of days, because the pulmonary pressure is still high, you may not see any signs of PDA, even if it is a even is the large PDA. So the signs and symptoms are not reliable in the first few days of life. So you may get a better blood gas in the first few days And then, after 3-4 days, you will see worsening of the respiratory acidosis. And initially you were able to wean down the ventilation, and then you have to go up the ventilatory settings. Oxygen requirement goes up, and the babies, started to show high blood urea nitrogen and creatinine, and then baby may show feeding intolerance, and there may be an element of hypotension. You can see the bonding pulse and White's pulse pressure. All these can be there, or but it may not say whether it is hemodynamically significant PDA or not. So in a ventilated baby, if the baby is doing well initially and then showing some worsening, then you can say clinically this is a hemodynamically significant PDA. Then you can do an echo. And while doing echo, you can look into some parameters like, diameter of the PDA. But, the flow depends not only on the diameter, the size of the PDA, because, the resistance, it depends upon the pulmonary vascular resistance and the length of the PDA also. If the length of the PDA is too long, you may not get, enough pulmonary congestion. So if you look into some parameters, just remember number 1.5. So the diameter more than 1.5, left atrial or aortic ratio more than 1.5, and these two things, if you remember 1.5, easy to remember 1.5. If this number is more than 1.5, it is a medium to large, and plus this parameters plus clinical, if there are evidence of a hemodynamically significant PDA, based on these two parameters, then you can think of treating the PDA. And the third parameters that you may not remember very well is mitral valve EA ratio. That is, EA means early diastolic filling divided by atrial contraction ratio. This indicate high pressure on the left atrium. If it is more than 1, is also suggestive of large PDA. So think about a number 1.5. So that's a number that you can easily remember.
Yeah, very nice take-home message and easy to remember, I think. So when would you really consider treating these babies? Like, when they will be symptomatic, or when they will be still asymptomatic, but we are doing echo. So how would you guide your treatment?
So the PDA is, as I mentioned,
let's see what the you can this, and then let's see what people would say.
Yeah, I mean, almost all babies are born with the PDA. It's a physiological thing in a PDA. So whether the treating PDA has shown is not shown any long-term neurological advantage for on treat, and most of the PDA, like 60% of the PDA, close by itself. And the medication has its own side effect, like Brufen or indomethacin has its own side effects. So you treat the PDA if there are signs of hemodynamically significant PDA, as I mentioned before, clinical signs plus echo finding, and if there is any difficulty in extubating. Nowadays, the tendency to extubate the baby as early as possible. So if you cannot extubate the baby within the time frame that you expected, then you can think of treating the PDA.
What do the others do, Nishad and Zahir? Are you doing routine echos and then seeing hemodynamic and giving the treatment, or you're balancing it out and then doing?
Yeah, just high risk cases or only selective cases, and treatment only depends on the need for ventilation and all those things. Not routinely we treat all babies.
Yeah.
The same here. The same here. We do not use universal. Sorry, we do not do universal echo on extremely preterm babies. Only those with symptoms, and then they will be targeted with treatment if they are hemodynamically significant.
Yeah, so because nowadays we are having lots of studies coming in which showed that the neurological outcome was worse in the babies who were treated rather than those who were not treated when they were not really requiring a treatment. So we have to balance. Okay, so a poll question: treatment of the hemodynamically significant PDA includes all except indomethacin, ibuprofen, paracetamol, and prostaglandin. Can you see the poll? I don't know whether we are able to see the poll or not. I'm not able to see.
Dr. Monica, you have to rotate the mobile. You have to rotate the mobile.
No, I'm rotating. I cannot see still. I'm rotating. I'm on the question answer. Nothing I can see the poll.
Yeah, it is posted actually. Yeah.
Okay, so can you see Ashraf, then you tell what is the answers given by people?
No, that I cannot see. Only the previous polls I could see.
Answer is posted in your group. You can look at it.
Yeah.
The answers are indomethacin,
The answer is
ibuprofen,
D, 60%,
paracetamol, and prostaglandin E.
D is 60%, and C is 40%.
Okay. Okay. So that's the answer, prostaglandin E. Now, good. So we have good. So what is the drug of choice in the treatment of PDA in your unit? So everyone unit is behaving in a different way. So quick, everyone can answer.
Oral ibuprofen would be the first choice.
Yeah. Ibuprofen is the first choice, but when I was in US, we use indomethacin.
Yeah. We don't have indomethacin here available, IV especially.
And Zahir?
Ibuprofen, either IV or oral, depending on the condition of the baby. Indomethacin is not no longer available, really, even from the manufacturer.
Yeah, I mean,
I have used paracetamol, but I'm a bit reluctant with the ongoing reports about long-term neurological issues with the use of paracetamol. This paracetamol is not proven as the main agent yet, so I advise people to maybe lean more on the ibuprofen. Oral ibuprofen is very, very good option. It's as effective as IV, and it's much less expensive. So if you are in a position where you can give oral ibuprofen, please do.
Yeah.
Yeah, so be simple. But paracetamol, yes, as you said, even the mothers who were given paracetamol, the babies, when they are seen as growing up, have been shown to have issues about the autism and that stuff. So we have to be more careful on that. But yes, if the baby doesn't improve with the Brufen, yes, we can think to be adding on the paracetamol. So that's okay. So this baby treatment for PDA was taken. We gave Brufen. All of us agreed to give Brufen, so that's what we gave. And we restricted the fluid. Ventilation continued. Septic screen was negative, and baby condition improved over next 24 hours. So everything which deteriorates doesn't mean the sepsis, and we are not supposed to go upgrading the antibiotics, and we need to see one-to-one case and then decide on our cause of the deterioration and act accordingly. So can we go for the next case, or
no, I think our time is up. We have lots of questions to be answered.
Okay. Thank you very much. And the questions, we are open for the questions. So we had 5 different cases, and I think we did the whole neonatology in this 55 minutes.
Thank you.
Tawfiq?
Okay, Dr. Joshi,
Yes.
you can put up the questions, please.
Yeah, I can read, but my video is not coming in.
Yeah, just click on I just sent you the.
No problem. Thank you, Dr. Monica and the team for finishing on time. And of course, being the opening pair of the annual conference, you've done very well. And I'm sure the conference is going to score centuries. Now, we have a few questions. The first question is about pulse oximetry.
We can't hear you, Dr. Joshi.
Can you hear me?
Yeah.
Oh, yes.
Yeah. The first question is about pulse oximetry. And the question asked is, are there any false positives and false negatives in the diagnosis using pulse oximetry?
Yes, there are false positives and false negatives also. That is why the timing of 24 hours was chosen. False positive is common with respiratory conditions, and false negative is common with few cyanotic heart disease and heart disease, which can be missed. So there are possibilities, and the rate is around 0.5 to 1,000. So there are both. So that is why the timing has been chosen at around 24 hours.
And Dr. Manoj wants to know if
I want to
there
add,
are
Dr. Joshi, I want to add on this that, when we talk about false positive and when we are doing within 24 hours, there is the time when we get this false positive. But we should always think, and there are papers who have come up that, these are not really false positive because they are not cardiac, but there are other causes which are causing it. So we should not just ignore it, and we should look at the baby completely, and there could be a sepsis, there could be pneumonia, there could be other things which might be causing, and baby might require some kind of attention when you get such kind of things. So when we say false positive, it means it's not positive for the cardiac, but then you need to look at the other things which is causing this. And false negative is very important, and we talked about it, that we should talk to the parents that it is not going to pick up all the heart problems, and some of the heart problems are not picked up and they may be coming up later. And so you have to tell the parents what could be the sign of heart illness and what is the importance of their follow-ups when they need to come to the neonatologist or the pediatrician back to see those things which may come up later on, like VSD. And even I have seen in my unit, even the critical cyanotic congenital heart disease was missed by the pulse oximetry screening, which we say it's not missed. So that thing has to be very categorically told to the parents. They should not go back home with a false belief that everything is fine.
I'd like to add one more thing. Even among the primary targets like tricuspid atresia, TGA, and secondary targets, hypoplastic left heart syndrome, it is not 100% sensitive to pick up these disease. It's around 80%, and few diseases is only 60 to 80%. So we should not think that it is always 100% for all these primary targets. That should be remembered.
Yeah, even those, even those.
Yeah. Related to this, there is a question on medico-legal implications. If you miss out a serious congenital heart disease in the newborn period and the baby manifests at 1 week with severe congestive cardiac failure, how much medico-legal implications are there?
So if we have documented a test, if we have done a test and documented, then definitely we are safe. But if you have not done a test and not documented, then definitely it's a problem. So that is why even this test is not 100% sensitive or specific. So we have to document whatever finding we are getting before discharge.
Dr. Joshi, I want to add on this. As we said, we took first and second case because of this reason, because we have to combine our clinical examination with the pulse oximetry screening. So when we are actually documenting, it's not just the pulse oximeter, okay, we did and it's fine. The documentation has to be, and we should have done our systemic examination before discharge properly, and that also should be documented. So we have to combine our clinical examination with the pulse oximeter to say that we did our job well. And still, sometimes we may miss certain thing. And the other third documentation should be that you told this to the parents, that we have still not said that everything is 100% correct. And that's the reason you have told them this could be the signs which the baby may present, and you should come to the emergency immediately. And you should tell to the parent that you should come to the regular OPDs for the regular follow-ups because of these reasons.
Thank you. There is another very practical question, is about the palpation of the femoral pulses in the newborns, especially small babies. It is difficult. Are there any practical tips on palpation?
Can I have a go at this? I think it is potentially easy thing to do, but on the other hand, it can be difficult to feel the pulses. My practical tip is obviously practice. That's number one. I think that is the most important. The more babies you see, the easier it gets. The way that I do it, and this is, I think, the standard way of doing it, is that while you are going to examine the hips, just before doing the hip examination, run your both fingers across the inguinal line, and then to pick up the pulsation simultaneously on both sides. Of course, moving babies, active babies crying, and also babies with difficulty in breathing, they may make it not easy for you to. But if you control the legs while you are doing, as if you are doing hip examination, both fingers, index fingers on the groin, and keep moving gently until you pick up the pulse, and stay there, stay still for at least 30 seconds. It will be relatively easy to pick up the pulses. If you are in doubt, that's again very important. If you are in doubt, however, no matter how senior you are, you can always ask a colleague of yours to double check on that. Thank you.
The question related to this only, it's about measurement of blood pressure in the newborn period. When you don't palpate the pulses, do you take it as a important sign for coarctation? Measurement of lower limb blood pressure.
It depends on the age of the baby, of course. Coarctation, as everybody knows, it may not present immediately after birth. But if you have any issues with the pulsation, femoral pulsation specifically, I think it will be a very, very important step to check the upper and lower blood pressure. Obviously, in these babies, initially it will be a cuff blood pressure. We know that we have reservations with the cuff blood pressure, but it's important to document that the upper and lower limb blood pressure has been measured, and hopefully it's normal.
The next question is on the frequency of congenital heart diseases, and what is the frequency of congenital heart diseases, and which ones need immediate surgical intervention?
Yeah, the incidence comes around, it varies depending upon the region. I think the study has published, I think from Cornish, a few years back, showed incidence around between 8 to 12 per thousand. That is the incidence, 8 to 12 per thousand. And the second question, what was the second question?
How many of them, and which are the ones who need immediate surgical intervention?
Immediate surgical intervention, it is, of course, the hypoplastic left heart syndrome, need immediate surgical intervention. And the TGA with the restricted PFO need emergency, balloon atrial septostomy. And TAPVC.
How early they can be operated?
The T means we have done the TGA with the restricted AST within the delivery room itself. The cardiologist came, and it's not from here, from the US, and then they did the echo and then did the atrial septostomy within the theater itself. So with a restricted PFO, you need to do immediately, and also the hypoplastic left heart syndrome, the Norwood procedure should be done as early as possible. TAPVC with obstruction is also one condition which need to be done as early as possible.
There are many more questions, but I will take only one now because we have the next session starting at 9 o'clock. This is not related to the topic which we are discussing. It's about the update on meconium stain liquor. What is the update on the management of meconium stain liquor?
So, anyone wants to take the question? Or?
Yes, I'll just have a quick comment, and then I'll leave it for you, Dr. Monica, if you have additional. No. Historically, meconium aspiration has been really tackled during resuscitation by very, very invasive ways, by intubating and then sucking through the ET tube. These guidelines have abolished. Nowadays, the approach is very minimalist. So you don't need to intubate and then and do that repeatedly, which is really putting the baby in a very, very unfavorable condition. So it's only if you see meconium, you do suctioning. If you don't see it, then you will be just approaching those babies pretty much similar to resuscitation steps that you do to other standard neonatal support or neonatal resuscitation programs. Afterwards, after birth, of course, the meconium aspiration, if it is significant, leading to meconium aspiration syndrome symptoms, you may end up in a situation where you have a pulmonary hypertension persistently, and obviously there are modalities of treatment, including the administration of surfactant, and then you will be talking about inhaled nitric oxide and adequate ventilation and so forth. So this is just a quick overview.
Yeah, and just wanted to add that even before that, like new infusion, that is also obsolete. So if our gynecologist colleague is asking us that we have this, so should we do immune? That is also obsolete. And only when you find an obstruction while you are intubating, then only you need to do the suction. Otherwise, you don't need to. And I'm very proud that all these evidences came from India, and they were all these three studies. They were done from India. With my friends had conducted those studies when the evidence came. Don't do anything to suction the ET on a vigorous or a non-vigorous baby. So that's the take home.
I think Dr. Banrai
Thank
also
you.
has one
Thank
question,
you.
Dr. Joshi.
Thank you, Dr. Monica. Dr. Monica, in the beginning, was worried about keeping the audience awake. Of course, your interesting discussion has kept everybody awake, and of course, in between, your picture in sari kept flashing on, so nobody could sleep. Without any further ado, I will go for the next session of the conference.
Banrai has one question.
Thank you, Dr. Joshi. Thank you, Dr. Joshi. And panelists, they had a wonderful information on congenital heart disease and how to find out and manage. Thank you, Dr. Monica and group.
Thank you. Thank you.
Thank you.
Thank you very much. Without further delay, we will go for the second part of the first session of the pediatric conference. Those people who are joined late, a warm welcome to the 6th annual pediatric conference. Of course, this is become an international conference because we have audience from all over the world, in fact, participating. The second session is on pediatric gastroenterology and hepatology. This panel will be moderated by Dr. Ajmal Kader. Dr. Ajmal needs no introduction. His detailed CV has been circulated in our brochure. I hope all of you have gone through the brochure. He is the consultant pediatric gastroenterologist and hepatologist at Dubai Hospital. And the session will last for about 50 minutes, and there are 3 panelists in the session. And this will be followed by question and answer. I request the audience to post the question and answer on the Q&A, which comes at the bottom. And please don't use it for personal messaging. Please ask only question and answers. May I request Dr. Ajmal to start the moderation of the next part of the conference. Thank you, Dr. Ajmal.
Dr. Joshi, before Dr. Ajmal joins, I'd like to give again some tips for the Q&A. If you want to join the Q&A, please click on the Q&A tab, pink color tab in the auditorium, and register your name and email once. Okay, then you can participate in the Q&A and polls. So please make sure to follow that. And Mr. Alia, can you?
And we can request the
panelists like Dr. Ajmal and as the panelists, from attendees to panelists, please.
we will. Tawfiq, let us request the previous panelists to join now through the other link.
So all the panelists of the neonatology can join as an attendee from the website link. Thank you very much for this.
You can leave this forum now and rejoin through the attendees link.
So, Dr. Ajmal, over to you.
Yes, we can see Dr. Miqdadi.
Yes, ma'am.
Good morning, doctor.
Good morning to you all. Oh, I see Ajmal.
Yes. Good morning. Where is
So we are waiting for Dr. Krish and Dr. Rajiv.
Rajiv is here.
Dr. Rajiv is here already.
Okay.
Venkatesh is not here.
That's
Yeah.
okay. We can go ahead and get started.
Yeah, we can start if you want.
I think part of the confusion, there was too many links and it was a bit confusing to know which one should be used.
Okay.
It's okay. You are on now. You can start, please.
Yeah. So I guess somebody is going to introduce me and then I take over, isn't it?
Yes. You have been introduced, Doctor, already by Dr. Joshi.
Okay. So am I?
You can start now. Yeah. You have to introduce the panel and please go ahead.
Good morning, everybody. We are going to do the gastroenterology panel. So we got good speakers and we've selected a few cases, which I think is practical use. So I have with me Dr. Mikdadi, consultant pediatric gastroenterologist and hepatologist. He is in Sheikh Khalifa Medical City, Abu Dhabi. And Dr. Rajiv Tomar is a consultant pediatric gastroenterologist and hepatologist in King's College Hospital, Dubai. And Dr. Krish Venkatesh, consultant pediatric gastroenterologist at Mediclinic Parkway Hospital, Dubai. So I will start off the presentation by, okay, let me get my slides on. Okay, hope you can all see the slides. Everything okay?
Yes.
Yeah, looks very beautiful.
Thank you very much for this kind invitation. I've been really honored to present our cases and also interact with you. I hope it will be a nice morning. We've got 4 sort of cases, a couple of gastroenterology cases and a couple of hepatology cases. And I'll start off with a little bit on the first case, which is related to a bleeding per rectum. So we all see bleeding per rectum in our practice, and the children mostly appear very well. And in our minds also, we know that most of them don't have anything serious. And very commonly, it is just a GI infection or constipation. And one thing I want to tell you, it is extremely rare to have malignancy as a cause of rectal bleeding. It's extremely rare. However, if the children are unwell and the bleeding looks something like this, you really have to work like hard and fast to resuscitate them and investigate them and manage them. So my approach usually is an ABC approach, not similar to the acute emergency. So first, A for age. As we know, the different age group have different etiologies and pathologies and management. And I always like to know the background, like is there a liver disease, is there a previous history of bleeding disorders or any sepsis, how the child looks like. So we need a little bit of background history, but not too much. And this is one pitfall we should really look for. We have to confirm the presence of blood because, as you know, children eat a lot of colored sweets, candies, and a lot of things which may look red and blood to the naked eye. So these are some of the things that can cause red color and some of the things that can cause black color. And honestly, I myself have been fooled and have scoped the child who had taken like a rose water fluid, which was the child was taking in excess and it was looking very red, and we just got caught out. So I feel very embarrassed, but it does happen, and I'm sure it has happened to many of the gastroenterologists. So please make sure that it is blood. And if in doubt, you can do stool or curl blood or alpha-1 antitrypsin to make sure, although these are very sensitive tests, but at least there'll be a little bit more evidence before you go ahead if you are in doubt. So my aim, once I know that, okay, there is bleeding and I've confirmed bleeding, my thought process is, where is the blood coming from? So it's quite simple from the history. If you just look at the color of the stool, is it fresh versus altered maroon color, or is it tarry black melena? Then I also would like to know whether the blood is mixed with the stool, or is it completely separate or coating the stool, or only blood. So I will just briefly describe a clinical scenario where we will attempt to identify the site of bleeding, and I'll summarize it before I pass it on to the next speakers. So this is a child in an ICU, the preterm child, just 13 days old. General condition is a bit less active, not very well perfused, and had a couple of episodes of blood of moderate quantity. And we confirmed the presence of blood with doing stupid. It looked very much like blood, and this child is not on any colored things. So we are very sure, but if you want, you could do a occult blood in this case. So how do we localize the site? So the color of, I will look at the color of the stool. It was altered or maroon colored. It was mixed with the stool. So I want to take a poll on what is the likely site of bleeding. Is the poll on?
Yes, it is
Yes,
on.
doctor, it is on.
On, okay. So I would like you to tell me where is the likely site of bleeding for this child. I can go back if you want. That it's an altered maroon colored stool which is mixed with the stool, and the stool is a bit loose.
I'm not sure if the poll is on because I cannot vote.
You will have to go to the.
Okay. Okay, that's
Yeah.
fine.
So the answer is like 100% A.
A, very good, excellent, that's fantastic. So yeah, so actually, I know most of you know this, but I really want you to do this exercise so that we can avoid a lot of unnecessary investigations and referrals and things like that. Fantastic, I'm so pleased that you're all very learned crowd here. Okay, so yes, indeed, it is a small intestine. Oops, sorry. You said A. No, it's not A.
No, it should be B. It should be B.
It should be B.
B, like in boy, yeah.
Yeah. Duodenum to cecum, small intestine. Yeah. So that's, everybody's wrong then. Or there is something wrong with the system. I don't think there is, it can be. Actually, my questions and the question in the poll, there is slight differences. Okay. Anyway, so this is an easy way of summarizing how to localize the site of bleeding. Fresh blood, if it's not mixed with the stool, it is very obvious. It's a very distal kind of bleeding, either just in the perianal area or in the last couple of centimeters of the rectum and anus. So fresh blood, as if you cut your fingers, bright red blood and nothing else, or just not mixed. The stool is separate. If it is fresh and it's mixed with the stool or slightly altered and mixed with the stool, it is from the large intestine, because the blood gets a chance to mix with the stool while in transit in the large intestine. If it's a bit jellied, quite dark, altered blood, it's almost certainly small intestine. And there are only two reasons why you will get melena. Either, of course, if you have ingested blood or some tablets and things which we are not discussing now, the bleed has to be somewhere where the acid can mix with the blood and make it dark and tarry, which is often proximal to the jejunum, which is the first part of so the stomach, first, second, third part of the duodenum, where the acid is still present. After that, usually the intestinal contents become alkaline and you won't get the acidity to make the hemoglobin black. And Meckel's diverticulum is another exception, where you, as you know, there can be ectopic gastric tissue, which can produce acid and cause the blood to be tarry black. So with that, I will just go on and we'll start the next presentation by Dr. Venkatesh. But I would like to say that the first thing you need to do when you see a child and after you have made sure it's blood is to rule out GI infections. Simple stool culture test can do that, and take a good history to see if it is constipation or not. If these two are ruled out, very often they end up having extensive investigation. So the important message is etiology varies with age, so think carefully. An older child is unlikely to have a bleed with just allergy. A young child is more likely to have a bleed with allergy. So more localizing needs planning investigation, and they have a low threshold to investigate. Don't ignore them. If it is persistent, yes, you have to investigate. Over to Dr. Venkatesh to present the next.
Thank you, Dr. Ajmal. Let me get the shares. Right. I think you need to come out of it, Doctor. Yeah. Okay. Right.
So I would like, while we are waiting, I would like to ask the panelists, what do you think is the average delay in diagnosis and investigating a case of bleeding PR?
We get referrals fairly early.
Okay.
That's my experience. Sometimes we get delayed, but on average, we get them on time. That's how I think.
And I see an average of 5 to 6 months delay in getting inflammatory bowel disease.
Wow, that's a bit too long.
Yeah, especially in an older child who just hides the symptoms, they don't tell the parents.
That might be true.
On and off bleeding, those kind of things. So it's actually fairly common to see that kind of delay for me.
Can you, I'm sorry, I'm interrupting. Can you see my, my?
We can see.
Yes, doctor, we can see. Just start the presentation, doctor.
Okay, thanks, Dr. Ajmal, and thanks for the organizers to give me a chance to present here. I'm just going to present a case of blood in stools just to see how they present and what could be the differential diagnosis. This is a true case that presented 3-4 months ago. A 3 years, 6 months old child presented with a history of passing fresh blood in stools for the past 3 weeks. Parents had noticed the stools about 5-6 times. The stools were coated with blood. They were not mixed in the stools, as Dr. Ajmal was earlier alluding to. And there was no other significant history, no history of constipation. The parents thought the child had occasional loose stools, but they were not actually increasing frequency in the stools. No other history which was of importance like abdominal pain, loss of appetite, weight, etc. Child was thriving. There's no family history of any inflammatory bowel disease or polyps, which would give a clue on what the cause of the bleeding or any history of infection. The weight of the child was on the 91st centile, but the height was on the 75th centile. The child was otherwise very well. There's no pallor, no jaundice. Abdominal examination was very unremarkable. There was no hepatosplenomegaly, no fecal masses felt, and as is expected, a perianal examination did not show any perianal fissures or skin tags. The typical examination otherwise was normal. So the question to the audience, where could be the site of bleeding? I think it should be fairly easy given that Dr. Ajmal has already mentioned about all the different reasons for having where the bleed is coming from. Can we have the poll? So the site of bleeding, is it from the upper GI tract or in the small bowel or in the colon, given the history?
The poll is on, doctor.
You have to check your mobile for the results.
Yeah. No, I will announce the result, doctor.
Okay.
So 40 more seconds to answer the poll.
It's a fairly simple question, and I'm sure everybody will get this answer right, especially after Dr. Ajmal's description.
Highlight something. See, you said there is no history of constipation. It's fairly easy for a 3-year-old because parents are monitoring them. But in a slightly older child, really you have to probe and get it out of some of the teenagers. It's not very easy to really get them to talk about poops.
Correct. That's true. Often they don't look at the stool. But there is no history of abdominal pain. There's no history of pain.
So the answer is like 46% colon, 31% small bowel, and 23% upper GI.
Fantastic.
Okay, right. I think given the history that is fresh blood and it is mainly coating the stools, it's more likely to be in the colon than in the upper GI tract. As Dr. Ajmal alluded earlier on, that it's less likely to be from the upper GI tract if it was not darker in color, or if it was coffee ground in color, if it was jelly in color, or maroon in color. So I think here it's fresh blood more likely to be the colon. So what are the different reasons of bleeding per rectum? I've just put in a few slides to get the audience stimulated. The first one on the left-hand side is infectious diarrhea. That is the cyst of amoebae, possible in this case, but there is no history of diarrhea. The one in the middle is what is the Meckel scan. You can clearly see in this scan that there is 3 spots there. One, this is the bladder, and that's in the stomach, and that's the one is a Meckel scan. Again, here the history is fresh blood, unlikely in this case, but just think of all the different reasons why children can have blood in stools. Intussusception, again rare, age is probably not suitable. There's no abdominal pain in this case, and the blood is fresh, unlikely to be, and it's occurring recurrent. All the intermittent intussusception is well known. Usually there are also significant abdominal pains and the child will be quite unwell. Again, I'll just put this video on. This is an endoscopy of a patient from the colon. I'm not sure if it can be appreciated. It's quite inflamed, indicative of possibility of inflammatory bowel disease. In this case, it is ulcerative colitis. Last thing I put up is a polyp. A polyp is a growth, a non-neoplastic growth generally in kids, which is a juvenile polyp. You can also have familial polyps, which we'll come to later. These are possible reasons why these children can have blood in stool. There are other reasons as well. In this case, more likely to be possibility of infection probably is there. Inflammatory bowel disease possibly is there, and rectal polyp is there as well. So these are the things that we need to think in this particular case. So how will we initially investigate? This is again a poll for the audience. Is it by blood tests and stool tests? This is the initial investigation. What do you do first? Do you send for a child for an ultrasound scan? Do you think we should do a CT scan abdomen? Should we do a Meckel scan straight away? Or you think we should take this child for endoscopy? Then we start the poll.
The poll is on, doctor. 44 more, 40 more
I would
seconds.
like to stress this is the initial investigation. You may do a lot of other things as well in the process. What would you first do of the 5 answers?
So the important thing here is it's a well-looking child, isn't it?
Yes, it's a well-looking child with no other symptoms. His examination is normal, weight and height is normal. And how would you first investigate in this case? Would you do a blood test or would you do a stool test? Or you look for ultrasound scan abdomen? I often see that a lot of people do send for ultrasound scan abdomen for somebody with abdominal symptoms. Here again, there's not many abdominal symptoms apart from blood in stool.
The answer is 1, like 71%, and 2 is 14%. CT scans 3 is 7%, and other 2 are like 0% and 7%.
Yeah, I think the audience also agrees that majority of them agree it's blood tests and stool tests, which we need to start with. We need to see what the basics are in terms of bloods. So in this particular patient, the full blood count was normal. It's important to know if the full blood count is normal for somebody who's had blood on several occasions. You don't want the child to be anemic. In that case, you need to probably act faster. The clotting was done. It was normal. Inflammatory markers were also normal. The stool microscopy was normal. Always it's good to look for the microscopy, and the culture sensitivity was also normal. We did just to rule out infection as a possibility, although given the history of no diarrhea, it was less likely. Occult blood was positive. There's more done to make sure that it was blood and nothing else, and it was, as Dr. Ajmal had mentioned earlier, other reasons of false positive blood appearance in stool. This was done even before the patient was referred. The calprotectin was elevated. It is, I'm just asked my other panelist, is it right to do calprotectin here, or should we have held back? What do others think?
I would vote for no.
Me too. I mean, I am a bit conservative about doing calprotectin because it just confuses, causes a lot of anxiety. A lot of people don't know how to interpret it, and it can have a lot of false positive reasons for elevation. So generally, if there is bleeding, I have to scope anyway. If the culture is negative, I have to scope anyway. I don't guide it with this one.
Can I also add that even if you like it, or if I like it or not, the insurance asks for it? and they reject that's what I've experienced. They'll say, what is the calprotectin?
Yeah, I know.
And I don't know who screens them, but insurance generally tries to ask if you have a colonoscopy, a calprotectin. Like you want to do upper GI tract, they'll say, what's the Helicobacter test result, whether it's indicated or not.
Okay.
I just will.
Yeah, that's a tricky one, where Krish. But remember, the message is not to do calprotectin only, for example, if it's abnormal or not abnormal for colonoscopy.
Correct.
That's what Ajmal is trying to. Yes, it's a clinical different scenario, like a teenager, bleeding, and we're suspecting XYZ, like inflammatory bowel disease. That's fine. But to be honest, on practical grounds, if you do it, I do it, I probably will do it. So purely for the same reason what you're mentioning, I think it tends to convince the insurance team better, maybe the patient or whatever. But anyway, I agree with Ajmal. If you have a scoping child who is well and the infections are ruled out, you would be scoping this child sooner or later anyway.
Yeah, correct.
The scenario where I do is when there is no bleeding, there's a lot of symptoms are suggestive of IBS-like thing, and I'm about to scope. And really, if in that case, if it's negative, I might avoid a scope. But in a case of bleeding, that's a totally different scenario.
Okay, great.
Yeah, I agree with Ajmal. You're going to scope this patient regardless. So the calprotectin is not going to make it, you're not going to make you do it or not do it.
So I did advise endoscopy in this particular case. Parents were not at all keen, especially because the child was well otherwise. I did repeat a calprotectin with due apologies from my other panelists, more to convince the patient than anything else that, we need to do an endoscopy. Given the calprotectin is elevated, given this blood in stool, there's something going on, we need to look at it. And I was surprised as well, it came up even higher. And the child was well otherwise, still had intermittent bleeding in stool. So we did go with the colonoscopy. In colonoscopy, this is what we found in the rectosigmoid, a well-grown polyp, single polyp. We did do the whole of the colonoscopy as is expected to see if there are any of the polyps and if there are any of the reasons why the child could have blood in stool. The rest of the colon was normal. The terminal ileum was also normal. I'll just put this video just to show what we did and how we remove. Polyps can be removed endoscopically. Normally you localize the polyp and you inject the base 1 in 10,000 madeleine, more so to reduce bleeding, and also put in a dye to see where the cut would be. Usually methylene blue is usually the dye. Then we use a snare polypectomy with cauterization. Make sure that the polyp is away from the abdominal wall so it doesn't lead to perforation. That is the key there. And then you cut it. Once that is cut, you make sure that the stump is okay and there is no perforation there. If you're not, you want to be absolutely sure, you can always clip it with a clip to ensure that there's nothing else going on from the site. And what you need to not forget is you need to retrieve the polyp. Here we use a basket to retrieve the polyp. The polyp was about 1.5 centimeters in size, and it was retrieved and sent for histopathology, which once again confirmed the presence of juvenile polyp. Just a couple of slides on what polyps and polyposis syndromes are. The commonest in children by far is juvenile polyps. Inherited hamartomatous polyps are much rarer. Again, there'll be a family history. Poisson-Jaeger syndrome, juvenile polyposis syndrome generally tend to be autosomal dominant conditions, and there would be a history. And they're slightly later in presentation, especially with Poisson-Jaeger's. Inherited adenomatous polyposis syndrome, like familial polyposis coli, again, there'll be a good family history. Gardner syndrome and Turcots are even rarer in manifestation. And again, the polyps tend to appear later on. Non-inherited polyposis can also be present. Lymphoid polyposis is also known. I'll just, because this is a case of juvenile polyp, I put a slide on it. It's the most common intestinal polyp lesions in children. More than 90% of all colonic polyps in children are juvenile polyps. They usually single, usual presentation age is 3 to 10. They're mucosal lesions which contain dilated mucous-filled glands, and they're highly vascular, and that's one of the reasons why they bleed. They're highly vascular, and when the poop probably causes the trauma, they bleed, and it will be intermittent. Often the child may not have everyday bleeding, and the management is endoscopic removal. no further follow-up endoscopy is actually necessary. Would all the panelists agree?
Well, sometimes it can fall off on its own sometimes.
That is true, actually. I had a patient who actually presented with the tissue, and we sent it. It came back as a juvenile polyp. That is true. Maybe the stool was so hard that it broke the polyp.
They can save a few thousand.
Insurance, isn't it? Yeah. I put a slide on calprotectin to just give an idea. It is present in cytoplasms of neutrophils. 60% of the cytoplasm of the neutrophil is calprotectin. It's often mainly to differentiate between irritable bowel syndrome in adults and inflammatory bowel disease. Can go up in any condition, infections, IBD, inflammatory polyps. The take-home message is you do calprotectin when there's a necessity. There's no need, probably in this case with the blood, just blood in stool and the child being otherwise well. In this case, it was elevated, once again indicating you just need an area of inflammation. You don't need the whole of the colon to be inflamed for the calprotectin to be quite high. Take-home message, painless.
Calprotectin, just to interrupt, is, as you mentioned, but you did not say, even things like Brufen, Helicobacter, all those minor infections and medicines can also elevate it. So you have to be very careful when we interpret this result.
Correct. If you're non-steroidal anti-inflammatory.
Yeah, one more thing to add. Calprotectin is not a confirmatory diagnosis for cow's milk protein allergy in younger children. I think it's being used rampantly for everybody who's having even eczema as an infant to rule out cow's milk protein allergy.
And it gives a lot of anxiety, and parents will be very stressed. I have seen as well, parents come with a child has the calprotectin 900, 800, and they want a colonoscopy when the child is really very well. There's no indication.
On this matter, maybe Dr. Migdadi can answer. Which is the best test for cow's milk allergy?
Thank you, Ajmal. The best test is elimination and challenge test. That's probably the best test to do.
History and trial of treatment rather than any tests or blood tests.
Absolutely. And the other thing about calprotectin, it's a concentration test, i.e. if the patient has diarrhea, it might get lower because it's dilution. So sometimes you see a patient who done a lab test yesterday in lab A, get a number of 300, and today you repeat it in a different lab, it jumps to 600. So you just have to put it in the context of the history, the physical exam, and the other findings to read it.
I would agree as well. I've had patients when you have repeated it, the very next day it comes very different. And that's because the calprotectin is basically how much of the poo is in touch with the inflamed mucosa, which leads to a raise in calprotectin.
Okay,
That's it really with my case. You should always think of other causes apart from infection or IBD for raised calprotectin.
So I think we have to harpen this point that please rule out infections, even if it is normal stool. If it's hard constipation, I can leave that culture. But even with normal stool, I tend to do kind of cultures before I scope a child.
While I would agree with Ajmal, my record of having cultures back when abysmally low, most of the time they are even in with significant, what we think is infectious diarrhea, they're negative. I'm not sure it's the labs or that has been the experience from the other panelists. The chance of having a culture coming positive is very low.
Agree. Same experience also, but if it is positive and you scope, you cannot interpret your biopsy.
Absolutely. Right.
Okay, can I have my screen back?
We had wonderful information. I appreciate all the participants for the wonderful presentation.
Okay, now we will go on to the, Okay, so section 2 is on jaundice and abnormal LFTs. I will start off with a quiz on, so whenever I see a child with jaundice, my very first thought process is whether it's gastro or not is first, because you know that you can have jaundice without a liver problem also. So the question is, how do you differentiate? So the three different type of jaundice: prehepatic, hepatic, and post-hepatic. So clinically, how do you differentiate? So that's the quiz about. So prehepatic jaundice is characterized by normal stool and normal urine color, or is it pale stool and brown urine, pale stool associated with normal urine or normal stool with brown urine. So just need 2 questions, but this question should be very clear to the patient as well, and you need to be able to interpret what they are saying. Sometimes you may have to show the colors, different colors and things, but if you are getting it right, it is very easy to differentiate between pre, intra and post hepatic jaundice. So can we have this poll, please?
The poll is on. We have 10 more seconds to answer. The results are like number A is 63%, B 13%, C 13%, and D 13%.
Okay, so yes, majority are right. It's a prehepatic jaundice where the liver is actually normal. The bilirubin is unconjugated. It is due to increased hemolysis of hemoglobin. So there's increased load of bilirubin coming to the liver, and the jaundice is because of that. So there is no obstruction, because if there is an obstruction, your stool is going to be pale. So because all the bilirubin is still passing into the intestine, your stools are normally pigmented, which is, we say, brown or green. And if there is no pale stool, there is no obstructive jaundice. And in an intrahepatic jaundice or post-hepatic jaundice, what happens is the bilirubin can accumulate, which is the conjugated bilirubin, because this bilirubin is unable to reach the intestine due to an obstruction, or because there's damage in the liver, this bilirubin is getting into the bloodstream, and the conjugate bilirubin is a water-soluble bilirubin which can go into the urine and make the urine brown colored. So in a prehepatic, it's always normal urine, normal stool. In intrahepatic, the stool is normal because there is no obstruction and the bilirubin is still reaching the intestine, but the urine will be brown colored because the conjugate bilirubin is water soluble and reaches the urine. In an obstructive jaundice, it will be pale stool and brown urine because the urine, because there is no bilirubin reaching the intestine and the bilirubin is going into the bloodstream and subsequently into the urine. I hope that is clear. So simple questions and history is always very important to understand some idea of etiology of the jaundice. So we'll move on to the next case by Dr. Mikdadi, Dr. Mohammed Mikdadi.
Fantastic. Thank you, everybody, for being with us all today. We're going to change gears and talk about something else. Before I start, I'd like again to say what Krish has said. Keep your mind open to all possibilities. All right, so in this case, my computer decided not to work. Yeah, this is a 14-year-old young girl who comes to you with jaundice for the last several days, and she's feeling tired. She's not eating very well. She has a decrease in appetite, and she has some kind of abdominal pain, although it does not look to be significant. A little bit nauseous, but no vomiting, and she felt a little bit warm, but there's no objective fever. All right. You go on and ask her in more details, past medical history. Recently, she developed anemia. It was thought to be hemolytic in origin. She has some difficulty in learning, and she's seeing a psychiatrist for several kind of visits. And they started her on some medications. They cannot remember the names of the medications, but these are the medications that increase your attention according to the parent. Family history. Her brother has G6PD. Remember, she has a little bit of hemolysis. And her mother is known to have thyroid, and she's taking thyroxine medication. And her grandfather from the paternal side is known to have a liver disease, and unfortunately he died with a liver cancer. So there is some family history of hemolysis, autoimmune disorder, and chronic liver disease. Moving on to examining her, she looks a little bit pale, and she appears jaundiced as well. She's well-grown child, normal growth parameters, her vital signs are normal. She's a little bit combative during the exam, really difficult to cooperate. And the liver is about 1 centimeter, probably that's normal, with questionable tenderness. You order some labs for her. Her hemoglobin is actually really was low, 7.9. Remember, she has this recent history of anemia and maybe hemolysis or others. Her ALT, AST are in the 400-500 range. Alkaline phosphatase is probably normal for this age, more than 500. Her total bilirubin is 10, and the conjugated is 3.7, so around 30% or 35%. Her albumin is 3.4, which is probably borderline, and her total protein is 8.5. Her coagulation screen is abnormal with a PT of 33. PTT is probably within normal, close to normal, 42. INR is a bit high, 2.7, which is actually significantly high. You did a quick abdominal ultrasound with Doppler, and it comes back as mild hepatitis. So let's go back. So in summary, a 14-year-old child previously healthy comes in with this jaundice, maybe some abdominal pain, questionable fever, family history of autoimmune disorder, thyroid, family history of chronic liver disease, and family history of G6PD. Also, this particular child has hemolysis. This is the picture we see. It's definitely she is anemic. There is a little bit of transaminitis, and she had high bilirubin, and obviously she's coagulopathic. So let's put the next question. In this patient, is she in liver failure? And if that's the case, is this evident by A, high ALT, B, high bilirubin, C, low albumin, D, coagulopathy? Tawfiq, can we get the poll?
The poll is on, doctor.
Okay, perfect.
We have 45 seconds to answer.
So what makes you go into liver failure? It's the high ALT, it's the jaundice, it's the low albumin, or is it the coagulopathy?
When I talk to parents about somebody who has a liver damage, I tell them there are about 500 causes of liver damage.
Yeah, probably even more.
It's an extensive list we have to go through and narrow down the possibilities, but only a few are treatable. So that's the challenge here.
Yeah, and our job is to find a treatable one and fix it.
Exactly. So the treatable one first, and ignore, not ignore, like keep the rest in the back of your mind. So we have the poll results.
Yeah, so
is D.
D, coagulopathy 65%.
Excellent.
B or D? D like in David, huh?
Yeah, D 65%, coagulopathy.
Oh, perfect. Yeah, yeah, because that's the key problem in this patient. If this patient has a normal coagulation, probably I will be very reassured. ALT, it indicates the damage to the hepatocyte. Of course, the higher the number, the more the damage, but does not tell you much more about the function of the liver. If this patient has an ALT of 1,000 and a normal coagulation, I would be reassured rather than the other way around. So, what's the differential diagnosis here? Again, keep your mind open to this differential diagnosis.
I'll just put a word there, Mohammed.
Yes,
so
sir.
Coagulopathy, you have to define it. Is it supported, unsupported, whether they gave FFP or so, it's a very labile thing. You can have changes in coagulation if you have given vitamin K or even clotting factors. So this has to be well defined.
Excellent point, Ajmal. Yeah, this is a case where we did not do any intervention. However, as you just mentioned, if you give FFP or factor or vitamin K or other factors, it might mislead you to that. Yes, and as you suggested, this since this patient has jaundice and it's probably a conjugated jaundice, since the direct bilirubin is more than 35%. Usually, the cutoff point is 15-20%. You have to worry about the malabsorption of the fat soluble vitamins. So in such cases, we give parenteral vitamin K, IV or IM, and you look for improvement. Usually the improvement happens, I would say, 12 to 24 hours after that. If it improves, it indicates this is a fat malabsorption, fat soluble vitamin malabsorption. If it does
Yeah.
not improve, it indicates intrinsic liver disease. Thank you
Yeah,
for
that's
highlighting.
Mohammed, this is very important. If it doesn't improve, then only you start thinking of liver failure. If it does, and you can repeat the PT hours 6 to 8 hours. You don't have to wait for 24 hours. So 6 to 8 hours.
Really? 6 to 8? Oh, okay.
Yeah, because that's the
sooner
half
than
life.
what I thought.
Yeah. So if you do that, then only you can start thinking of defining as liver failure.
How many doses of vitamin K do you give, Rajiv?
I give 1 to see the response. 1 is good enough. And I think there are different doses based on, the micrograms per kg, but the standard thing is whatever the age of the child is, give that much milligrams. For example, in your child, she's a bigger child, but smaller children like 5 or 6 years, you'll give 5 to 6 milligrams of vitamin K, repeat over 6 to 8 hours. And if the INR is not improving, you start thinking of liver failure.
Of course, you have to put the clinical scenario in place.
Of
If it's
course,
chronic
of course,
liver
yes.
disease, you may get fat malabsorption. This is fairly acute, so it's unlikely, but still, it's always better to give it.
The whole idea is that if you have chronic liver disease, you do expect some malabsorption happening. And vitamin K malabsorption, we can lead to abnormal PT. So that's the whole idea of giving parental vitamin K to bypass that thing. And if it improves, then probably liver was fine in that sense, but there was a malabsorption leading to vitamin K.
Excellent, Rajiv. Let me just repeat what you said about the dose of the vitamin K. As you said, we give 1 milligram per year of age. So if the child is 2 years of age, you give him 2 milligrams. If he's 3, you give him 3.
It's easier to remember, otherwise it would be 300
Yeah, exactly. Yeah. And the
Yeah, I
maximum you would give 5 or 10? Is that
10
your max?
for your child, I will give 10, 14-year-old.
Okay.
Yeah.
Excellent. Okay.
I think the usual dose, in my understanding, is 0.3 milligrams per kilo. But I think it's easier from what Dr. Rajiv said to remember and give. You need a good dose of vitamin K.
Can't poison them with vitamin K.
Yeah. So 0.3 milligram per kilo, but I think, age milligram, I think, is also fairly.
Perfect. And the other thing,
we have 8 more minutes for the panel, doctor, then 10 minutes question and answer. Okay. 8 more minutes for the panel.
Let me just mention one thing that I think Rajiv and Ajmal alluded to, which is we don't know if this patient has a chronic liver disease or not, because the, liver disease usually is silent. So this patient could have had a chronic liver disease without having any symptoms. So the differential diagnosis, again, keep your mind open. I think there are several possible diagnoses here. The first one is drug-related. This patient is taking several medications for attention, or maybe sometimes some mega doses of vitamins and others. So always drug-related is a differential diagnosis in anybody with liver disease or jaundice. The second one is possibility of autoimmune hepatitis. Autoimmune, because remember, the mother has a thyroid disease, so that goes with autoimmune disease. And the other thing is that this patient has hemolysis, so autoimmune hemolysis could be the case. The clue to autoimmune disease actually is this, that remember the total albumin is low and the protein is high. So the difference between 8.5 and 3 is about 5, and this is probably immunoglobulin IgG, so this might be suggestive of autoimmune disorder. The third one is this could be acute or chronic viral hepatitis, hepatitis A, possibly to look like this exactly, hepatitis B, hepatitis C. And remember that not only A and B and C, we have another long list of the 500 that Ajmal mentioned, the other viruses, adenococcus, CMV, EBV, and many other viruses that can cause that. And many times we call it viral
Daddy, 5 minutes left. Please, one more case is there, I think.
That's fine.
Okay, I'm done. And the last differential is Wilson's disease. The SPGAN says Wilson's disease should be in the differential diagnosis of anybody with abnormal liver after the age of 1 year, especially that this patient has some kind of a neuropsychiatric disorder. Thank you very much for listening. I think I will stop here.
Okay, our next speaker is Dr. Rajiv Tomar. He's predominantly a hepatologist and he also has a liver case. Rajiv.
Okay, I'll start quickly. So, yeah, the aims of this presentation is just to mainly focus you guys to how you will interpret a liver function test in a particular clinical context. And in between, I'll be having same question for the poll, but the answers I'll be discussing later, not with the subsequent questions. So quickly, this child is a 9-year-old boy who was admitted with a very short history of fever and jaundice for 10 days.
Sorry to interrupt you. Can you make it full slide?
Is it not?
No.
It is. It is.
Slideshow.
It is
Slideshow.
No.
Slideshow.
Okay. Can you, is it better?
Yes, thank you.
Okay, fine. So a quick history, 9-year-old with a very short history of fever and jaundice for last 10 days. Parents felt he had a little bit of bloating, tummy distension for last 1 month. There was nothing in the past medical history. Family self-consanguineous parents, but no significant medical history in the family. On examination, general examination, the child was deeply jaundiced. He had pedal edema. Examination of the abdomen showed his abdomen was mildly distended. His liver was 3 centimeters below the costal margin. Spleen was also palpable, which was 3 centimeters, and the rest of the systemic examination was essentially normal. So question number 1. Is this an acute presentation or is it an acute or chronic presentation purely based on the history and the examination? Simple question. Can I have the poll, please?
So there are some cutoffs for acute and chronic, isn't it? The cutoff timelines for acute and chronic. And I think it's quite, it depends on which book you're reading.
No, I'm not talking about acute or chronic as such, but generally speaking, are there features?
Acute and chronic liver diseases.
Yeah.
Especially acute liver failure.
Perfect. Do you have the poll?
Yeah, the poll is on. 8 more seconds to answer. A is 32% and B is 68%.
Okay, good. So I'll discuss the question answers later on. So moving forward, I'm sure most of us will agree and will do these tests in a child who is jaundiced and looks slightly unwell with the CBC, CRP, liver function, clotting profile, both PT-INR and APTT. It's always a good idea to do a blood sugar and a renal profile in these sick-looking children. We always do blood culture and do start them on broad-spectrum antibiotics till we get the final diagnosis done. Since it's an acute presentation, so we always do the hepatitis screen, which involves the hepatitis B, A, E, and as Dr. Magdadi said, the viral serology, there can be hundreds depending upon the clinical scenario, and we always get an ultrasound abdomen done. So the second question for the poll is, will the following be your initial workup? Number 1 is for the autoimmune liver disease, and number 2 is your workup for Wilson disease. And I'm giving an option for you would do nothing, you would do only for autoimmune hepatitis, or you will only do for Wilson disease, or you will do both. This should be easy after listening to Dr. Mohammad's presentation. Can we have the poll, please?
The poll is on. We have 19 more seconds.
There's also a link to your first poll, actually.
Yeah, that's why I didn't tell the answer.
So it's a bit unfair, I think.
We'll have a discussion soon.
So the answer is A 27%, B 0%, C 27%, and D 45%.
Okay, that's quite variable. So, okay, we'll have a discussion about this soon. So let's only discuss what was the positive finding on this initial workup which we had. So the CBC showed the child had lowest normalish platelets of 150. The hepatitis A IgM came back as positive, so that was worth doing it. However, the ultrasound was showing coarse ecotexture of liver, gallbladder was normal. There was no other mass in gallbladder, and the hepatosplenomegaly was there with a minimal ascitic fluid. This was something which is interesting to note, and something should have triggered your mind at this stage, because if you stop thinking that it was only hepatitis A virus, it only needs conservative treatment, this may not be the right approach, as we'll find out.
So hepatitis A, I just want to check, Rajiv, how sensitive and specific is it?
I think if it's positive, it's quite important, especially in the context of fever and an acute presentation. I didn't mention that it was a history of recent travel from abroad. So that makes it quite interesting. So coming to sensitivity, I don't know the exact figure, but I think it's quite sensitive test if it's an IgM thing. We don't do any more specific viral PCRs for this. We're happy with if it's negative, if it's IgM.
Yeah. Okay.
So just a couple of minutes just to focus on these liver function. That's the crux of my presentation. The important thing is not to look only at the abnormal results, because we tend to just look at what is highlighted red in our reports, but it's also important to look what is normal liver function test. There is no one liver function test which will help you to make a diagnosis. Yes, it's a combination of multiple functions as there are multiple etiologies. So if you look at the bilirubin, we all agree it is a conjugated hyperbilinemia. Very rarely at this stage, you would get an unconjugated hyperbilinemia. Predominantly jaundice at this stage, and most of the cases will be conjugated. Just focus on the AST and ALT. Now we know where they had the hepatitis A, which was positive. So you see an initial spike in AST, ALT, day 6 going to 510 and 434. And what is interesting is by day 14, the AST remains relatively high, but the ALT improves much better. This is all on supportive treatment. The key thing is to look at the ALP again. Again, as I said, anything which is normal also needs attention while interpreting a liver function test. Again, as Dr. Magdadi mentioned, so whenever you see a protein in albumin, please do your maths, do subtract it and find the globulin. In this case, the albumin is low. That should raise a trigger, unless you have any other disease which may be causing, a protein losing. If it's purely liver and if albumin is 2.9, that is unlikely because of hepatitis A infection. And clearly, when you subtract, the globulins are within the normal range. INR, I think we've discussed enough. It is coagulopathy, vitamin K given, didn't respond very well, but with supportive treatment, became essentially normal by day 14. So just
one question. Why do you say albumin of 2.9 is unlikely to be because of hepatitis A alone?
Yeah, because albumin essentially has a half-life of around 20 days. As I said, if you don't have any associated diseases, for example, you may have associated kidney disease where you're losing albumin there, you may have associated gut disease where you'll be losing albumin there, but it's a pure liver disease. And if you have a low albumin, then probably this is something which is not acute because the half-life is 20 days for albumin.
Anything less than 20-30 days, unlikely to affect the albumin.
Exactly. And as I said, you have to make sure the child is not losing albumin from other systems. If it's pure liver disease.
I partially answered your question, first question.
Yeah. Okay, good. So moving forward, please remember this slide because the discussion is based on this now. So what's your working diagnosis?
5 minutes left for your question and answer session. If you
2 minutes, I'll finish, Dr. Shore. I'll be very quick. So I'll skip this poll. I think the answer here is acute and chronic liver failure. And let's quickly discuss the interpretation. Why was ALT initially very high on day 1, day 6, as we discussed? Because of the hepatitis A infection the child had. So what does the following suggest? A late AST, which is much higher than the ALT. Remember the day 14, the AST was higher than the ALT. The albumin has been low throughout the admission and the child had ascites. This suggests the child has chronic liver disease. The diagnosis is acute on chronic liver failure. The importance here is that although it was unlucky for the child to have hepatitis A infection, but it gave us the opportunity to figure out this child had underlying chronic undiagnosed liver disease. This was an opportunity for us to listen and focus to start working on what could be the underlying chronic liver disease in this child. So other results came back. The child had mildly raised IgG of 1880. He had a positive anti-smooth antibodies, but ANA was negative, raising possibilities of autoimmune hepatitis. But the child also had low cerebroplasm, which was but with the normal serum copper levels. Again, confusing that it could be a Wilson disease. As Dr. Magdadi mentioned, now the recommendation is anything which is acute or chronic or simple abnormal liver function test. These two diseases should come into your mind, especially if the child is above 2 to 3 years of age. The presentation can be quite variable, subtle, chronic, acute on chronic, or simple acute liver failure. So keep these two diseases definitely on top of your mind. And remember, will a positive antibody confirm entombment? The answer is no. There is a lot of cross-reactivity in Wilson disease, and a very common scenario is nowadays is non-alcoholic fatty liver disease in children. There's the cross-reactivity positivity of around 20%. And with all due respect, the adult hepatologists, not all of them, some of them will have a tendency to start steroids in these children, which could be quite detrimental for these children. Is any particular level of cerebral arousal which
Excuse me. We have 5 more minutes, including the question and answer session.
I'm finishing now. So is the serum copper important? No. The diagnosis of our child was acute and chronic liver failure. Hepatitis A was infection, which triggered the whole thing. Chronic liver disease, we're working on autoimmune hepatitis and Wilson disease. And as I said, please do not start steroids based on purely positive antibodies. Do not start penicillin just because he had a low cerebroplasm, because if you start penicillin, it can decompensate the child. So make sure you send this child to a higher liver center for further management. What happened here, the KF ring was not seen in our child. It's generally seen above 10 years. However, the 24-hour urine copper was abnormal, and subsequently liver biopsy confirmed the child had liver disease. Genetic studies takes time, but they also confirmed the child had liver disease. So in summary, history and examination is the key. Remember, this child had abdominal distension of 1 month before he had fever and jaundice for 10 days. So that was a very clue there was a chronic liver disease going on. It's a very important thing. Whenever you have acute liver presentation, please do focus on liver function tests, as it can be an indicator of undiagnosed chronic liver disease. And this is the opportunity to start treatment for those chronic liver disease. Remember, simple positive antibody test is not a diagnosis of autoimmune disease, and please do not start treatment based on this. I think I'll be quick. Thank you very much.
Thank you. We can take the question.
Very good case.
Please, 1 or 2 questions. Rest of the question will be sent to the email of respective panelists, because time is short. 1 or 2 questions, please.
Yeah, thank you. Thank you, Dr. Ajmal and the team, for finishing on time. Many of the questions are answered already in your lecture. There are a few which were not answered, and I will like to ask them now. The first question is about the polyps. Maybe this question is about the juvenile polyps. After treatment or after removal, how often do they recur? What is the recurrence risk? And the second question is about the syndromic polyposis. How do you investigate them, and how often do you follow them up, maybe regarding the endoscopy?
So Venkatesh, you can answer that, please.
Juvenile polyps are usually single. They generally don't recur. You don't need to do a repeat endoscopy once you remove the polyp. In case the child became symptomatic again with blood in stool, then you probably need a repeat endoscopy. It's well known that when you do an endoscopy, polyps can be missed. In one study, 22% of the patients of the study did show they had missed polyp in the first colonoscopy. Sometimes this can happen, but they're rare. The second question about polyposis syndrome. In polyposis syndrome, usually there'll be a family history. De novo is much less common. Familial adenomatous polyposis, you don't start screening them until they're about 10 or 12 years old, after which they need to have yearly, 2-yearly screening, and then yearly after that, if you see polyps. And the polyps will be, of course, biopsied or removed for histopathology. Familial adenomatous polyp at 3.5 years in this particular is very, very unlikely. They don't present this early. They're much more later in presentation.
They all get a genetic screening and things like that also.
Yes.
So the next question.
The next question is about the non-alcoholic fatty liver disease in children. What are the LFT abnormalities that you normally see?
Mohammed, do you want to answer that?
Sure. For non-alcoholic fatty liver disease, first of all, it's a diagnosis many times of exclusion. You have to rule out the other more common causes. I would suggest at least to do a viral workup for chronic hepatitis and Wilson's disease, and the other causes like autoimmune disorders and others. In non-Arabs, probably alpha-1 antitrypsin deficiency disease medications. If after you have ruled out all these more common ones, then you might consider fatty liver disease. Fatty liver disease typically is a silent disease in somebody who's overweight and usually they get a blood test done for whatever other region, and you find their liver enzymes to be high. And if you do an ultrasound, you might see a large liver with some fatty infiltrate. But all the above are so non-specific, and we have to rule out other causes before we call it fatty liver disease.
Yeah, if we have to choose one test which is not 100% sensitive, just do an ALT, although it can be normal in 20% of cases. The ALT is your so-called the best slot in the common liver function test.
Exactly.
The last question, probably it is the lengthiest, the answer will be the lengthiest. The question is about the emergency management of GI bleeding, upper or lower.
Well, it's about resuscitation again.
ABC.
First of all, is resuscitation. Endoscopy is not the initial treatment. You resuscitate, stabilize the child, and at some point you will go and do the scope. But very rarely, if you cannot stabilize, really impossible to stabilize, yes, at that time you would intervene endoscopically, and at that time probably the surgeons also should be around. If you really cannot stabilize clinic with your ICU setup, then an endoscopy can be done. But usually we stabilize them, ABCs, and then we scope. And again, if there's this huge bleed and you endoscope, you cannot see anything. It's just bleeding all over. It's where you really wouldn't see much. For that reason also, you wouldn't go in straight away heroically. And also taking a child to theater, you're making the child taking the child outside a safe zone of ICU. So it's going to be quite risky. So stabilization first, and then a semi-urgent endoscopy. But if it's crashing case, yes, no choice. You have to go.
Yeah, and if I may comment, doing an endoscopy in somebody who's like, acutely bleeding is not fun. You cannot see much, you cannot do much. So stabilize the patient, try to delay the endoscopy till things settle down a little bit is the best thing. Before you transfer the patient for our general pediatric colleague, make sure he has enough fluids, enough volume, correct the coagulopathy, and hopefully improve his hemoglobin a little bit.
I would agree as well. The other issue would be that, when you scope, I think usually there's clear guidelines, and when you scope these patients, you can wait up to 24 hours before you scope, stabilize the patient, make sure the patient is not anemic, and you have enough blood on board before you go in as well. Now, of course, you need a pediatric surgeon. I would totally agree with that. You need a surgeon next to you in case there's more problems.
Okay, I think.
Thank you very much. Dr. Bhandari, if you have any comments or questions. Otherwise, we'll bring an end to this session. Thank you for all the panelists for making the session very interesting. And with your permission, we'll move on to the next session. Thank you very much. The panelists can log out of the panel, please. Thank you.
Okay, thank you very much. You have enjoy the rest of the day.
Enjoy, yeah.
Before we start the next session, I just want to give again some housekeeping tips. Like audience, all are requested to press on the Q&A tab once to register your email and name, so that you can be able to participate in the polls and the question and answer. Dr. Saurabh,
we come to the next session. The next session of the Dubai Pediatric Club Annual Conference is being chaired by Dr. Saurabh and Dr. Kalpana. Dr. Saurabh doesn't need any introduction. He's the backbone of the Dubai Pediatric Club, and he's the face of the Dubai Pediatric Club on all the social media. He is currently for a long time working with NMC Hospital as a specialist pediatrician. Dr. Kalpana also needs no introduction. She's the organizing secretary of this conference. She is the head of the department at NMC Specialty Hospital as a specialist pediatrician. And they are going to chair the next session. Can I hand over to Dr. Saurabh to start?
Thank you very much, Dr. Joshi, for a kind introduction. Thank you very much. Good morning. Once again, I would like to welcome all viewers. I'll just want to give this announcement that at the end of this conference, we are going to felicitate the senior members, and of course, a special ceremony. We will felicitate them and give them the certificate and tokens of appreciation. Now it's my great pleasure to introduce the moderator of the next panel, pediatric surgery panel, Dr. Diari Mohammed. Dr. Diari is very well known. He doesn't need any introduction. Dr. Diari is the senior consultant pediatric surgeon at Latifa Hospital, Dubai. Without wasting any time, I would like to request Dr. Diari to introduce his panelists and start the session. Thank you very much.
Thank you, Dr. Zorab. Good morning, dear colleagues. In the coming 1 hour, we will start our panel discussion with the three eminent and dear colleagues, pediatric surgeon, Dr. Nadim Haidar, who is a consultant pediatric surgeon, Dr. Jundi, who is a consultant pediatric surgeon, and Dr. Hussein, who is a consultant pediatric surgeon. So without delay, we will start our panel discussion today. And as I am on?
Yes, we can hear you.
We can hear you, but
and my slides?
not yet.
Not yet.
Okay, just a minute. I have to
Share the screen. Yep.
Yeah, we can
Now?
see now. Can you run the slides?
Can be seen?
Slideshow.
It's okay?
Yep.
Yes.
Sorry. So we have a pregnant lady she is 28-week gestation with a male baby diagnosed antenatally to have left-sided diaphragmatic hernia and polyhydramnios. And she has been referred to a pediatric surgeon from the fetal-maternal department. So, Dr. Nadim,
yes,
you
sir.
are counseling this lady, and you are giving an advice to this lady and to the obstetrician and our neonatologist. So what will be your way of counseling and what you are usually discussing with the parents?
Okay, Assalamu alaikum and good morning, friends. And thank you for giving us a chance to be a part of this discussion. Antenatal counseling in the congenital pediatric surgical conditions plays a very important role, especially ones which can have poor prognosis. So in this case, this is antenatally diagnosed. So the mother and the family needs to be prepared for what will happen to the baby when the baby is born. So the first thing in the counseling is we go through the different types of scenarios that will be faced, how early this is detected, what the anticipated prognosis can be, and the anticipated prognosis in terms of good and poor has its own prognostic factors, which I'll go through when I go through my presentation. But more to prepare that when the baby is delivered, the baby should be delivered in a tertiary center, which has a complement of a well-developed neonatal intensive care unit and a neonatal ICU and pediatric surgeons, and a unit that is used to dealing with such conditions. And then the discussion comes on to what the mode of delivery will be for the mother. And that is a discussion between the neonatologist and the obstetricians. There seems to be a controversy as to what the best mode of delivery is. And I don't think there is a very definite recommendation. There are people who would deliver these by elective cesarean section, and most of us would go with a planned elective section close to term or once the baby hits term. But normal vaginal delivery can also be offered. And the neonatal intensive care team needs to be aware of the time of the delivery, and the most senior neonatal team members need to be present. At the time of delivery, as soon as the baby is delivered, bag and mask ventilation should be avoided as long as possible, and the baby should be immediately intubated. After intubation, it's preferable to paralyze or give neuromuscular blockage and put the baby on positive pressure ventilation, making sure and that the ventilatory settings are such that we can try to avoid or as much as possible barotrauma. And we'll also tell the mother that the baby will have different tubes, or nasogastric tube, which will decompress the stomach and help with the baby's respiration. And this can be a big problem, especially when there is intestine in the thoracic cavity. And the baby will have different lines, and this will be to help monitor, so that when the mother sees the baby, she doesn't get upset, or she doesn't feel she's not expecting this. After the delivery, sorry.
Just Dr. Nadim, I have just here two questions to you. Now, you mentioned you like to have an elective cesarean section, because this is very important, because what we know usually we like to be a normal vaginal delivery, which gives much maturation during the birth canal delivery to the lungs also, especially to the right lung. So as you mentioned, there is controversy, but most of the time they can be delivered by normal vaginal delivery.
So as long as we can let the baby hit close to term and there is no emergency, then spontaneous vaginal delivery is what we would recommend. But elective cesarean section after the baby hits term can also be an option, and that sometimes has to do with the local demographics and the fact the availability of different types of expertise at the times of the day or times of the week.
Yeah, my second comment here, do you ask the neonatologist for a muscle relaxant or deep sedation? Usually.
I personally ask them for a muscle relaxation, because this is once again one of those things where I think it makes it easier for them right from the beginning to try to control the ventilation. I know there are people who go for deep sedation, but my practice has always been muscle relaxation.
Okay, so go ahead, Victor. What's the postnatal, usually your postnatal imaging, or what's your start of postnatally, how you will start with the X-ray, with the ultrasound, echo, and what is the benefit of?
Fine. So this is a baby where we have already made an antenatal diagnosis that there is a left-sided diaphragmatic hernia. So we would like to confirm our diagnosis. Sorry, and to confirm the diagnosis, a chest X-ray, a simple chest X-ray is usually enough, but especially when there is an antenatal diagnosis that has been made. But the presence of air and fluid-filled shadows in the chest can also be confusing for a primary lung abnormality. So if this was not an antenatally diagnosed case, or if I have any doubts, then an ultrasound postnatally is the next step to go to. Because what we are trying to differentiate is making sure that this is not pulmonary sequestration, or that this is not a congenital neurogenic or a bronchogenic cyst, or it's not a sequestration or primary lung tumor.
Yes.
So after we confirm the diagnosis and the baby has been stabilized as much as possible, the first thing I would usually, after the baby has been stabilized to the maximum, I would ask for an echo. And the echo usually is to not only to look for the associated abnormalities, but also to look at the function of the left side of the heart, and as well as the degree of pulmonary hypertension. So in terms of imaging, I think that is most that we will require soon after delivery and during the first phase of management.
Now, timing of surgery previously was regarded as an emergency. Do you think it is an emergency surgery?
Absolutely not. And I'm glad that you have raised this question, because there have been times, so this is, I'm talking about pediatric colleagues and not the neonatal colleagues, because there are times when we discuss this on our rounds or with our colleagues, they are surprised when we say that surgery is not an emergency. And when you say that you can wait 5 to 7 days for surgery, some of them really don't want to believe you. But I must stress and confess that the improved mortality or the improved outcome in congenital diaphragmatic hernia is mostly because of three, or at least in my view, because of three factors, one of which is the gentle ventilation techniques, the introduction of ECMO, and the third thing is delaying surgery for when the child is stable. So that time can be anywhere between 2 to 5 days or 7 days. And
we have one patient, 31 days we wait. 31 days.
So I think what you're looking for is the patient to be stable. Sorry.
Stable, yes. Stable.
And that stability means that
coming to surgery.
Sorry. Yeah.
Yes. Go ahead, Dr. Malik.
Go ahead. I was going to say that stability, we need to make sure that if as much as possible that the child is back on conventional ventilation. So if they're on high frequency, we try our best that they're as close to bringing them to conventional ventilation. If they are on ECMO, then we prefer that they are decannulated before we do that. There are people who would operate on children in ECMO or operate early, but the results of those usually are not very encouraging.
Okay, coming to the surgical management of this part, maybe mostly for the surgeons. You know, before 10 years, everyone was doing laparotomy for diaphragmatic hernia. And now with advanced technology, now there is laparoscopy, there is thoracoscopy, and still some centers doing laparotomy. So what is the pros and cons of these surgical maneuvers?
Okay, so the best method of repairing diaphragmatic hernia depends on the surgeon's experience. So if I do not have experience for minimally invasive surgery, then I think open surgery is still the safest.
Absolutely.
And is still recommended. Sorry.
Absolutely.
But the pros and cons are and differences between open surgery and minimally invasive surgery usually is that when we are going for open surgery, it's a bigger incision. It's more painful in terms of recovery, or you require more post-op pain medication. And there is more handling of the intestine, so we create more adhesions, so the chances of post-op adhesion obstruction are far higher, which when we go with minimally invasive surgery, which includes laparoscopic as well as thoracoscopic based on the surgeon skill and experience, we can complete sorry.
Yes. Yes,
we can complete the surgery with small incisions, small port sites, which we use for instruments, and there is less handling of the intestine, especially if we are doing it through the chest, thoracoscopically. And in terms of outcomes and recurrence, they are very similar, but the difference is that the post-op requirement for analgesia are far less. When we're using the minimally invasive surgery, and we believe that the handling of the intestine also, because it's all instrumental handling and not powder-driven gloves or glove and hand handling, which is slightly more adhesion encouraging way of surgery, we also create less adhesions.
Okay, last part. What's about the long-term complication in diaphragmatic hernia? Just a few minutes, 1-2 minutes.
Okay, so when we are looking at long-term complications, one of we start with the sequelae is that they are known to have thoracic abnormalities, post-op thoracic abnormalities, which can be kyphosis, scoliosis, or they are oxygen dependent. About 25%, from what I remember, are oxygen dependent around at the time of discharge, or even at 1 month of age. But by the time they hit 1 year, only 2% will require oxygen. When we have done the hernia repair, because of the way we have handled the diaphragm, and there is an element of dysmotility, most of these children, or at least 50% of these children, will have post-op gastroesophageal reflux, which will make it difficult for them to feed for some time, and that is what leads to failure to thrive. So some of these children will fail to thrive in the early part of the recovery period. They will also, because of what I mentioned before, there is a 20% incidence of intestinal obstruction from adhesions. There is also, it depends on the center you work in, between 20 to 30% chance of recurrence. The recurrence is based on the technique that you have used, the capability and experience of the surgeon, and a number of other factors. So I think when you look at the long-term sequelae or long-term complications, these are ones that I would normally mention to the parents at the time of counseling.
Nadeem, for this very nice talk regarding the diaphragmatic hernia repair. And as just you mentioned, it is mainly depend on the surgeon experience to do minimal invasive or to do laparotomy and reduction. Thank you very much. As you mentioned, some cases of diaphragmatic hernia are associated with other abnormalities. And in this particular patient, when we found that there is a Meckel diverticulum. Dr. Jundi.
Yep.
Now you are the surgeon and you are doing this surgery, either laparotomy or thoracoscopy or laparoscopy, and you found some other associated abnormalities, like in this patient, a Meckel diverticulum. What will be your approach?
This is a very controversial issue, actually. The incidental finding of Meckels. There is actually a criteria for resection of incidentally found Meckels. I would look at the length, at the base, at the length, if it is long, at the base, if I can find any ectopic mucosa. Of course, all these factors play a role in whether to resect it or not. It also really depends on the situation at the time. I mean, in such a baby, 28 weeks old, doing the repair through thoracotomy, I think it would be difficult to remove the Meckels.
Exactly.
However, as I said, this is a controversial issue. The criteria is clear and is very helpful in deciding whether to remove it or not, actually.
Okay. So, and personally, when you are doing, let's say, in this case, I am not concentrating on this case, thoracoscopically, it is almost impossible to do it through the chest. But sometimes if we are doing the laparotomy and you are bringing it out and it is in front of you, it is a long one, it is, maybe there is a twist and these things. So usually it's better to be resected. Now, a Meckel's diverticulum, is there?
I agree. Yeah. I agree, particularly if there is a band, if it is long, if the base is narrow, if I can discover any ectopic mucosa,
which is difficult by eyes.
Which is difficult, yes, absolutely. Yeah. And the gender of the child
gender is important.
Makes a role, because its complications are much more common in males than females, and yeah. And the age of the person the age of the patient. The younger the patient, the more reason to resect it, because the lifespan is much longer and complications are more.
Yes. So as you just mentioned, incidental finding, there is a risk of complications. So can you elaborate on that? What are the mainly usually we are seeing complication of Meckels?
Well, Meckels, there is bleeding, obstruction due to either volvulus or internal hernia or intussusception. There are some other unusual perforation, of course, perforation, diverticulitis.
You can see this.
As we know, the incidence of Meckels, we all know the rule, the classical teaching as the rule of two, which is not strictly correct, actually. In children, the complication rate is about 5% of Meckels. Males are 3 to 4 times more prone to complications than females. And in symptomatic groups who come with, I mean, there's 88% we can find gastric mucosa, 7% pancreatic mucosa, and 3%. Now, we've talked about the presentation. I mean, either as acute abdomen due to perforation or diverticulitis, or intestinal obstruction due to volvulus, intussusception. Bleeding is one of the main complications as well of Meckel's, and that would be due to the peptic ulcer in the bowel due to ectopic gastric mucosa in Meckel's. And incidental finding, of course, during laparotomy for other reasons. Most commonly it is confused with appendicitis, and we open for appendicitis and we don't find appendicitis, and we find Meckel's, infected Meckel's or necrotic Meckel's. Unusual presentations as well. There are some unusual presentations like inversion without intussusception and retained foreign body in Meckel's, and the perforation due to abdominal trauma. Perforation in Meckel's due to abdominal trauma. Of course, I mean, the diagnosis is, we either find it incidentally, or we do an ultrasound. I'll show you the ultrasound in a minute, or technetium scan. There is a CT scan, of course, the MRI, which are not really very helpful sometimes, most of the time. Okay, but there is no role for contrast in diagnosing Meckel's, but it has a role in probably refuting other causes of intestinal obstruction. This is how Meckel's on ultrasound looks. It's a blind loop with thickened wall. And this is the technetium scan, and we can see the spot in the middle of the abdomen, which represents ectopic mucosa, ectopic gastric mucosa. The complications, the overall complications are 5% in children, but they are less in adults. The obstruction constitutes about 40% of cases of intussusception in a very large study. It was done, and the obstruction was either due to intussusception, volvulus, or internal herniation. The bleeding, or what we call hematochezia, painless bleeding, was 38% of cases, diverticulitis in 15%, and umbilical pathology in 6%. Criteria for resection in incidental Meckel's: the length, less than 2 centimeters, without any evidence of ectopic mucosa. There is no need to actually to resect it. If the base is wide and there is no evidence of ectopic mucosa, no evidence of band, no band, nothing. Also, we may leave it and not resect it. But if there is a band, we have to resect it. The younger the age of the child, the more reason to resect it, actually, because the complication is higher in younger age group. Gender, male. If it is a male, the decision has to be taken, but it's more likely will be resection rather than leaving it behind. Ectopic mucosa, of course, if there is any evidence of ectopic mucosa, which is very difficult sometimes to diagnose by palpation or by vision. If there is an evidence of ectopic mucosa, resection is advised. We either, I mean, surgically, we either do wedge excision or we do segmental resection and primary anastomosis. What I personally do usually, if there is diverticulitis and volvulus, I would do resection, or segmental resection and primary anastomosis. In bleeding and incidental finding, wedge excision should be sufficient. In intussusception, it depends how the Meckel's look. If it looks necrotic, gangrenous, unhealthy, then it's better to do segmental resection and primary anastomosis. That's it. Thank you very much. If you have any questions, I'm quite happy to answer those.
Thank you. Can you just
I'll stop sharing my screen.
Yeah, please.
Just let me get back to my screen. Okay, first. Okay. How to stop sharing? Yeah.
Now I am there. My slide is seen.
I'm just trying to stop sharing my screen. Which I'm not sure how.
Dr. Hussein, my screen.
The same,
Okay.
same green button.
Yes, Dr. Diari, we see it.
Yeah, okay. So as just Dr. Jundi mentioned, I will just put for you a few slides to see what we mean by perforation of a Meckel diverticulum. You can see it.
Just put it on a play, Dr. Diari. Yes, please.
Yes.
Thank you.
Yes. And intestinal obstruction, as Justin mentioned, the older the age, the more intestinal obstruction, the below 2 years, mainly bleeding. You can see when there is a Meckel and it is necrotic, it is torted. Sometimes it can present with torsion. So it will be an acute abdominal pain. It can be bleeding, as just it's seen here. And this is the Meckel scan. I think our colleagues, gastroenterologists, they ask also, or they show bleeding per rectum with a Meckel. It looks like a large amount of blood, one attack, usually painless, or as Dr. Jundi mentioned, Meckel diverticulum can cause intussusception. Again, a foreign body can stuck in a Meckel diverticulum and cause perforation. And sometimes when you are going to do an inguinal herniatomy, you can find some prolapse of a bowel loop which contain the Meckel. And now what I want just to highlight here, in Latifa Hospital, almost every incidental Meckel we are resecting. It is unlikely to keep a pathological incidentally find Meckel, which should not, we are not keeping it intra-abdominally. And then after that, anytime this patient coming with little bit of abdominal pain, then we are thinking that this might be diverticulitis, this might be Meckel problem. For that, when we are doing laparotomy and we are finding a Meckel, we are resecting it. This, as you mentioned, it is controversial, maybe debating, but in our practice, it is like that. Dr. Hussein.
Yes.
Again, when we are looking for one congenital abnormality, actually, we have to look for other congenital abnormalities. And in the same patient with diaphragmatic hernia and incidental finding of Meckel, this patient was having this anomaly. So he's a boy with this umbilical anomaly. So how you will comment on this?
Yes, so the remnant of the cord is enlarged. It's a big one. I see some reddish. It could be a mucosa. It could be a granuloma. So for our pediatrician's colleague, if this is a presentation to the clinic, so the first and the most common diagnosis is the umbilical granuloma, which is by far much more common than any other problems of the umbilicus at this age. But this one looks a little bit bigger and a little bit, the umbilical cord itself is much wider. So other anomalies, particularly in this patient with another congenital anomalies, we should suspect others. So what it could be, if it is not a umbilical granuloma, so I will suspect either this is part of one or two mucosa from the remnant of the vitellointestinal ducts, though we saw the Meckel's diverticulum, which is part of this vitellointestinal duct at fetal life, or it could be mucosa from remnant of the urachus. Just to remind our pediatricians that both the urachus and the vitellointestinal ducts are part of in fetal life. They are reaching to the umbilicus, to the yolk sac. And when the baby is born and the umbilical cord is falling down, so all these remnants will fibrose and leaving in its place some anatomical mark. For example, the urachus will leave a median umbilical ligament. It's exactly at the midline. But sometimes it could be patent. while the vitellointestinal duct either leave a fistula, sinus, a tract, or a Meckel's diverticulum. So these, we should think about all these differential diagnoses.
So coming back to this patient, what you can see the difference between this and the other one.
Yes.
This is a clear omphallomesenteric duct, patent omphallomesenteric duct, because even we can see the meconium in it.
Exactly.
This is a little bit confusing. There is a little bit discharge from this umbilicus. Is it a remnant of the urachus, or it is a remnant of the omphallomesenteric duct? Is it patent, or it is a sinus or a cyst just got infected? As you mentioned, the most common presentation of urachal remnant is a cyst. Most of the time they are cysts and they might be infected. So usually we are seeing, what's your opinion, patient coming sometimes with, or let's say, what is the most common complication of urachal?
So, Dr. Diari, this photo particularly, the one that you are putting down the slide, is a common representation, and really it is difficult to start with, because most of the time, as we said, the most common diagnosis or the differential diagnosis is granuloma, and most probably this patient was treated before as a granuloma by either silver nitrate, cauterization with a pinch of salt, whatever it is. And these, if they are recurrent, not dissolving more than 2, 3, 4 times, in that case, it's raised a suspicion. So after examination, still with this photo, very difficult to differentiate. So we need to go further. For example, to do an ultrasound of the abdomen, just to check if there is a remnant of the urachus, like a urachal cyst, or if we can see a band sometimes with the ultrasound, it gives us a hint that this could be something more serious, just granuloma, which needs further investigation. So with this one, I'll go now for an ultrasound, looking for a cyst or a connection to internal organs.
Sure. Okay. So sometimes even by ultrasound, it is difficult. They might need a CT scan, even more than that. So this is our patient, Dr. Hussein.
Yeah. So when you put a pressure by your fingers, there is some urine coming out, I guess. And this means that this is a connection with the bladder, which means it is a patent urachus, but this is a wide and a big one.
Yeah. So how you usually investigate a patient with patent urachus?
So patent urachus is it's like, let's say, a tract or a connection between the bladder and the umbilicus. If we can see an opening and we put a catheter and do fistulogrammy or sialogrammy or whatever contrast that we can inject to see the connection to the bladder. This is number one.
In this case, you don't need that.
This could be associated in 1/3 of cases with a distal obstruction, distal urinary tract obstruction. So we may go further to do an ultrasound even to the kidneys, to the bladder, and we may need to do MCUG, micturating cystourethrogram, to find, first, to diagnose the connection, I mean the urachus, and number 2, to rule out a distal obstruction like a posterior urethral valve, for example.
So in this patient, you can see the MCUG, which is clearly patent and it is open to the umbilicus.
That's right.
Yeah. And this is when we usually say that when we are going to investigate in order
You're breaking up, Dr.
install some dye or some, yeah?
Can you repeat, please?
So Dr. Diari, this is an ultrasound, what? Pardon, with a dye, a specific dye inside it?
Yes, yes, inside by like MCUG, and you are seeing the tract which is going to the umbilicus. Yes,
that's
exactly.
right.
Yeah. And because he was having diaphragmatic hernia, and this, we let him grow more, and he was passing the urine from this side. And then the surgery, how you will do the surgery for these patients?
So for this one, patent urachus, we have...
Because before, sorry, this is his cystoscopy. when we went in to rule out the posterior urethral valve, although by the MCUG was not clear. So this is the penile urethra, and this is, we are going now to the proximally to the posterior urethra. Then we are seeing the verumentanum. We are going in. We are looking here for the posterior urethral valve. If there is a posterior urethral valve, and luckily there was no posterior urethral valve. Yeah. Yes, and then we went in. This is the verumentanum. That's the posterior urethra.
Fine, fine.
Yeah, and then we went in and we are seeing now the top of the upward is the fistula anyhow. So surgery is, yeah.
So in most of the cases, the surgery, we do a gentle, a simple umbilical incision to find the connection coming from the abdomen, from the, for example, from downward and reaching to the umbilicus, and I go through this connection to dissect it completely as far as I can reach close or even to the bladder to excise it from there in order not to leave any remnant of it that may cause problems or diverticula in the future.
Exactly.
And like what you are showing, a complete excision of the urachus is the choice.
And this is the bladder, and we remove part of the bladder or the dome of the bladder. Why? Because there is a risk of malignancy, adenocarcinoma in this area when you are leaving. So this is, you have to be very careful in that part also.
Yes, that's right. If you can reach it, so you excise it and you put sutures on the dome of the bladder. Perfect.
And this patient, because his now abdomen is open, Dr. Jundi, and because he was having a diaphragmatic hernia repair, there is risk of adhesion, risk of intestinal obstruction. Then we brought out his Meckel, which is really big.
Makes sense.
Yeah.
It makes sense.
It makes sense. It is in the same surgery to remove it. And this is the final look of it with the circumcision because he's a male.
Nice umbilicus.
Now, Dr. Hussein, last question to you. A lot of pediatric patients, 4 years, 5 years, 6 years, coming with recurrent suprapubic pain or abdominal pain, and you do the ultrasound and incidentally you found a urachal cyst. And even this one, it is almost pressing on the bladder. You
right.
See what will be your approach?
So for a cyst, for a remnant urachal cyst, either they are presenting with symptoms of the pressure of the mass itself, if it is growing, and like this one, for example, is even causing, I see it's indenting on the bladder dome itself. So the size may be one of the reasons that it causes symptoms, or sometimes it may get infection, and they are present with pain, lower abdominal pain recurrent, or sometimes even they may present in some patients with cellulitis of the abdominal wall and abscess. So if it is infected like that, cellulitis, abscess, first I treat it with antibiotic. Abscess, sometimes we need to drain. Incision and the drainage. And if it is not like, and then I wait for a while till it's complete or resolution of the infection, then I go and do a complete excision of the cyst. So the ultimate goal is to do a complete excision of the urachal cyst. Without infection, I go directly to do the excision. With infection, first to treat infection and then do the
drainage, infection, and then excision. Absolutely, you are right. Now, in two cases, we might remove part of the bladder if a vertical around the bladder, or if it is a patent urachus. Thank you very much for three of you, Dr. Nadim, Dr. Jundi, and Dr. Hussein. With this, I'm finishing my session, and we are happy to receive any.
Thank you very much, Dr. Diari. I would like to thank your panelists, Dr. Ayman Jundi, Dr. Hussein Najian, Dr. Nadim Haidar, for excellent presentation and discussion. And of course, you covered most of the questions. Dr. Kashif is asking, of course, I'll ask this question in three parts. Do you operate immediately after birth, this diaphragmatic hernia?
Who was asking, sorry?
Dr. Kashif.
Kashif. Yeah, Dr. Nadim, I think we answered this one. Yeah, tell me.
We've said this, that the era of operating immediately post-delivery is gone. Even if the child is stable, we do not operate immediately because there is what we call as a honeymoon period, which lasts for 24 to 48 hours. So most of us, even in the presence of a stable child, will wait between 1 to 2 days before we operate.
Oh, thank you very much. The one question I'll ask in two parts. What other specialities you involve in the management of diaphragmatic hernia? And 40 years back when I started medicine, the treatment was different, now it's different. How do you, what do you think in next 10 to 20 years will happen to the treatment of diaphragmatic hernia? What, innovation may come? Please, any one of you.
Yeah, actually, as Dr. Nadim mentioned, innovation is already there. The most important thing is nowadays going on is the fetal-maternal surgery. The fetal-maternal surgery by tracheal occlusion to create the lung. The pathology is the lung. When there is no lung or there will be hypoplastic lung, will create a problem for the other lung also as a pulmonary hypertension. So up to date now, there is what's called the tracheal occlusion in order to grow the left lung or the lung which is affected. Dr. Nadim, if you have any.
Sure. And if I'm allowed 10 seconds, I have a video clip which shows the tracheal occlusion, how we occlude it and how we remove the balloon. Will the panelists allow me to share that?
At the end of session, we'll play this one. Not if you have more question, I would like to request Dr. Kalpana also to ask question. At the end, we'll play the video.
Sure.
No, yeah. So there was a comment by Dr. Vaspi who said that there could be associated malrotation in these cases. So yeah, apart from that, there were a couple of questions on the raised pulmonary artery pressure. So especially after post-surgery. So do you see when the pressure by the lung is taken off, by the intestines is taken off on the lungs? So a comment on that to deal with the pulmonary artery.
Yeah, Kalpana, I will answer the easy one and I'll give the difficult one to the Ari to answer.
Sure.
Okay. So the first part about the malrotation, it can either be a malrotation or a non-rotation. So they do not always require surgery. It depends on what we find at the time of surgery. And if I see some non-rotation, I would not fix it at that point in time. I would repair the diaphragmatic hernia and then go back later based on symptoms, based on upper GI contrast imaging. We sometimes then selectively deal with that condition. But this is an association with diaphragmatic hernia, which we see a lot of the times, and we don't always operate on them.
Actually,
may I just add a comment, please?
Mr. Wasfi knows better than all of us. He is our pioneer. He just probably asked this question for the pediatrician, not for the surgeon, because in diaphragmatic hernia, malrotation is a part of the pathology. It is pathology. It is a non-rotation most of the time.
Yes,
So
but the question is, Dr. Diari, the question is whether to do something about it or not. This is
no. It is part of the disease. No, you will not do anything with it.
Even if you find a very narrow mesentery.
Now, look,
where the likelihood of valvulus is much higher.
I personally, I did not come across any surgeon till now who is doing LATS procedure or repair of malrotation because this is a non-rotation which is part of the pathology. So no, my answer is no.
Emin, remember that this is mostly non-rotation and not malrotation, and we mix up the terms. So as long as it's non-rotation, if the base is not that narrow that we are discussing requiring.
Yeah, I've never done it, by the way. I'm just asking because there is a bit of controversy about it. Just to clarify.
Another question.
Go ahead.
Another question would be the percentage of cases that you see PU valves in association with this, and maybe to Dr. Hussain, couple of questions on umbilical granuloma. You mentioned that this looks like granuloma if it was much smaller. From pediatrician's point of view, somebody wants to, Dr. Manoj wants to know, correct method of applying silver nitrite, and how long do we wait for spontaneous resolution? In other words, when will you think that this is not granuloma and it could be a patent uricus? What should pediatricians look out for?
So in most of the time, these cases are presenting with something protruding from the umbilicus, whatever is the reason, to pediatrician. And pediatricians seeing them as the first differential diagnosis is umbilical granuloma. Whatever is the treatment method, where some of them are using a pinch of salt, myself and other colleagues are using silver nitrate, or sometimes I do direct cauterization with bipolar cautery to remove it immediately and get rid of it. The question was also about the method, how I use it. So first, when I use the silver nitrate, I put a Vaseline ointment on the skin, on the normal skin, because you cannot avoid the silver nitrate from touching the skin, whatever you do. So the best method I found is to put some Vaseline as a protective layer, and then put the silver nitrate on the granuloma itself, touch it from all the angles. Then I put a cover, a gentle cover for 1 to 2 hours in order not to let spillage of this to the normal skin or to the clothes. And then I wait. I tell the parents, and most of the time, one may be enough, particularly for small granulomas. Larger one, we may need to see the patient after 1 week, or the parents can look and observe. If it is disappearing, no need to come back. But if it is still there or discharging, I do another, second, third, up to 5 with silver nitrate, but 1 week in between. I don't do it every 2-3 days. It's better to give it a time. So sometimes 3 to 5 times if we do, and still it is bulging or large, or there is an ooze, for example, either we may suspect urine, the smell of it could be urine, or we may suspect feces. In that case, even before that, I may go further to do the investigations that we talk about, to rule out other congenital anomalies like the uricus and the vitellointestinal duct remnants.
Right. And the PUVAS, how often is it associated?
Which one, sorry, the patent?
Posterior urethral valve.
Oh, it's in 1/3 of the cases of patent uricus. We are talking about the patent uricus, not the urachal cyst, not the urachal fistula or sinus. These are usually, we don't go and looking for distal obstruction of the urinary system, only when it is a patent uricus, which means urine coming from the umbilicus. This is a patent uricus. The Foley tract is still open. In that case, 1/3 of cases, so it's a large amount of, large number of patients. In that case, it is mandatory to go and search. We need to go the MCUG or the different modalities of radiology techniques to find the distal obstruction, or cystoscopy, even cystoscopy.
Sure, thank you.
May I ask one question I want to ask all of the panelists? Antenatal, ultrasound. What are the fallacies, false positive, false negative? Which condition you really, you can diagnose, for sure. Other, false positive, negative, just highlight that.
Yeah, Dr. Zohrab. Nowadays, a lot of cases of especially the urogenital problems, especially renal problem, we are diagnosing antenatally by ultrasound, especially hydronephrosis, multicystic dysplastic kidney, and diaphragmatic hernia, for example. We can diagnose duodenal obstruction because of distended stomach. We can dilate it and echogenic bowel by ultrasound. We can antenatally. So gastroschisis, omphalocele, meningomyelocele, and the most important, for example, in gastroschisis, almost weekly we are doing ultrasound to see if there is dilatation of the bowel. When there is a dilatation of the bowel, sometimes we are doing the antenatal ultrasound twice per week. Then we are elective cesarean section, premature delivery, in order we don't want the amniotic fluid with the gastroschisis to be oedematous bowel. So antenatal ultrasound helping a lot nowadays. Posterior urethral valve, as part of the workup of the genitourinary, there is a lot of diagnosis of the bilateral hydrourethronephrosis, which indicate posterior valve.
So this branch, Dr. Zorab, has developed a lot in the last 20 years. So before, I remember, just for a joke, in some countries, the pregnant ladies are going there just to check with ultrasound to know whether the baby is a boy or a girl. Nothing else. They are not diagnosing anything else, probably the length, probably the development, the amount of amniotic fluid, and nothing else. So it was very difficult before 20 years to find any diaphragmatic hernia antenatally in some countries, I mean, in the Middle East and other countries close by. But recently, something around 80% of the cases of diaphragmatic hernia, we are diagnosing them by ultrasound when it is done by a professional and good hands. So it changed a lot. Now, most of the cases, as Dr. Diari mentioned, congenital anomalies are diagnosed very early.
What about fetal surgery, doctor? How would you say that has progressed?
It is a new branch. It is progressing a lot in a lot of countries. And recently, before a couple of weeks here in
UAE.
In UAE, it was the first case that they did meningomycin antenatally in a fetus, and it was a successful procedure. So this is a very interesting and progressing branch. It is coming more and more, I guess.
Yes, I think.
Question we can have. Because we have today a surgery panel, surgery quiz. So let us keep some questions for the quiz.
Yeah, we can. I think we can stop the panel now, doctor. Most of the questions have been answered. And
so I would like to thank the viewers. I would like to mention that at the end of this morning session, there will be a raffle draw. Please stay tuned. And afternoon, we'll have a lot of quiz, clinical, surgical. I would like to thank Dr. Diari, Dr. Ayman Jundi, Dr. Hussein Nazi, Dr.
Dr. Nadine, Dr. Zorab, Dr. Nadine is having his few seconds. He's in Pakistan.
Oh, yes. I'm sorry. I'm absolutely sorry. Yes, please. Get time for that. Yes, please.
Just give me 2 seconds. I'm sure it will be interesting for many people.
So, आप मेरे जान लीजिए. Continue.
So how do I share? Do I go onto the screen or whiteboard?
Come on now.
Screen, you're already sharing, doctor.
Can you see my screen?
Yeah, we can see your screen. Just click on the presentation to open it, doctor.
On the video.
Just 1 minute. Okay. Yeah. So can you see my screen? Because I can't.
Yes.
Yeah, we can see, doctor.
Okay, just 1 minute. Yes, so that's fine. So Saurabh, this is just in answer to your question. So when there is an antenatal ultrasound, this is what we look for, and it is usually very easily picked up in professional hands. Now, this is the antenatal intervention that I wanted to play. So, and I will only play from the point where you can see things. So it's loading.
This is the counseling, antenatal counseling.
Yes. So Scott Edzik is a very big name in fetal surgery.
Can you make the sound louder, Nadine?
Maximum.
Okay.
No sound? Yes.
Fetal bronchoscope is passed through this trocar and then into the baby's airway. And then under direct vision, we actually blow up the balloon and then detach it and leave it in place. Moms stay in the Philadelphia area for a good 3 to 4 weeks afterwards, so that we can prepare her for the balloon retrieval.
So then comes the balloon retrieval.
Gestation around 34 weeks.
Once the lung is developed.
This, the first and the easiest way would be if we could puncture it with a needle, and then because the pressure behind it is stronger, have it just come out of the fetal mouth. And that would be attempted. If that's not successful, we can't just puncture it. The next step would actually be to repeat the procedure that was performed before. Again, another small incision after lining it up with where the fetal mouth will be, and then passing a fetal bronchoscope into the airway. And this time it's loaded with a grasper in order to pull that balloon out. Families would be required to deliver at the special delivery unit.
Thank you very much. Once again, thank you very much, Dr. Diari. Dr. Jundi, Dr. Hussain Naji, Dr. Nadim Haidar for excellent presentation. You finish in time also. I thank for that also. Now we go to the next panel. Next panel is pediatric neurology panel. Dr. Kalpana Sengupta is a chairperson. Dr. Kalpana Sengupta needs no introduction. She is the secretary of the club, head of Department of Pediatrics and MC Specialty. Dr. Kalpana, please, mic is yours.
Yes, it gives me great pleasure to introduce our panelists, neurology panel. Are they with us now? Dr. Aman Sohel?
Yeah, we are just promoting them as panelists.
Right, yes. So maybe we could request the
Now,
surgical.
like Dr. Aman is there already.
Okay.
So one thing, Dr. Kalpana, I want to request all viewers to stay tuned. We have a raffle draw with lot of prizes at the end of neurology, pediatric neurology session. So stay tuned. After this session, which will be very interesting, we'll have raffle draw. And at the end of today's conference, we will have a name of active members of the Pediatric Club. Yes, Dr. Kalpana, please.
Yeah, and I think now most of the queries about the audience that they have raised about the polls have been answered, and most of the people are able to answer, I hope, take part in the polls. So yeah, we will be starting our pediatric neurology panel now. Dr. Aman Sohal, leading consultant pediatric neurologist, co-founder of Neuropedia, will be heading this panel. Dr. Aman, I hand over the mic to you to introduce your panelists and start the panel.
Dr. Aman, can you switch on your camera, please?
Yeah, I can see Dr. Arif and Dr.
Now he's
Vivek.
there. Yeah, please.
Right. Sorry, I got
Hello, Doctor.
Disconnected for a second. So have you done the introductions and we are about to start, is it?
You've been introduced, Doctor, and now handing over to you to introduce your panelists.
All right, let me just get my bearings right. Give me one moment, please.
Sure.
Okay, thank you, Dr. Kalpana, and good morning, everybody. This is a great privilege for all of us pediatric neurologists to be here in this lovely forum. And it's an absolute pleasure presenting some of the really good cases by expert pediatric neurologists in UAE. Three of my very close friends are in the panel, who I'll introduce one by one, and then we'll go straight to our discussions. We have Dr. Vivek Mudanda, who is a close friend from UK. He trained in the UK. He's a consultant pediatric neurologist, was in India for some time where he practiced, and then he's moved to UAE now. He's currently based in Medcare Women's and Children's Hospital and doing a great job there. Recently, he managed 2 kids with SMA and provided gene therapy to them. So congratulations to him. We have Dr. Arif Khan, who's an extremely close friend, and we go back a long time. Many years we've been together in the UK, and here in UAE we are both partners in a small place called Neuropedia, which is the only children's neuroscience center in the country. We have Dr. Mohammed Mekki, which I cannot see on the screen, but I'm sure he's somewhere along there.
Doctor, he was there, but I cannot see him now. I think he's logged out.
Okay, so if you don't mind calling him up, please, and I will introduce him as well, because his talk is the last.
Okay.
Dr. Mohammed Mekki is a consultant pediatric neurologist, and he's currently working in University Hospital Sharjah. He trained in Johannesburg, and soon he's going to move to, I believe, to Al Qasmi Women's and Children's Hospital. So without further ado, I will put the house forward for Dr. Vivek, who's going to present the cases, one case, and then followed by Dr. Arif's case number 2, and then Dr. Mohammed Mekki, who will present the case number 3. And like all other panels, we will start the discussion. The house is over for you, Dr. Vivek.
Hey, good morning, everybody. Thank you, Dr. Aman, for this kind introduction. So we'll just quickly go through the first case. Brief background of this case. So this is a case about a 13-year-old girl who came to see me with the background diagnosis of cerebral palsy and associated with epilepsy.
Vivek, can I interrupt you there for a second? Just hold on for a second, please. Tawfiq, can we hear Dr. Vivek properly?
Yes, everything is clear.
Okay,
Because
so we can
Vivek
hear
is online now.
Little louder, it is better. Little louder.
Fantastic.
I'll increase the volume.
So,
Okay.
sorry, carry on.
Yeah.
Carry on, Vivek.
Okay. So this is a case of a 13-year-old girl who came to see me with the background diagnosis of cerebral palsy and comorbidity of epilepsy. She goes to a special school in Dubai called Al Noor School for Children with Disability. And basically the parents visited me with the agenda of just getting her medication refilled or prescribed, because her usual neurologist is somewhere in India, and the parents used to travel every 6 months to see the child neurologist there in India. Now, this was the background, and I didn't have any other history or medical report because parent just came for prescription to me. They wanted me to prescribe her anti-epileptic medication. She was on oxcarbazepine 150 milligram twice a day, clobazam 0.5 milligram at night. And there was some antipsychotic medication, which I wasn't sure why she's on, and that included lithium and olanzapine. Now, the dilemma here was...
So I will take it from there for my panel. So first of all, this is a very important point Dr. Vivek has made, the medication refills, which suddenly walk into our clinic. So let me put the question to our panel, and I'll start with Dr. Arif first. So Dr. Arif, what is your advice, when somebody just comes into your practice and says, doctor, I've come in for a medication refill. So what do you do in that situation?
So that happens very common. I mean, it's a pretty common scenario we come across, but I don't prescribe. That's the short form of it. Unless I have a call from the primary doctor who's been looking after the child, or the child is known to our organization with all the records available so that we can visualize that and make a repeat prescription. If they just come for medication for the first time without any kind of information, I don't.
So thank you, Dr. Arif. Dr. Mackey, any comments on that? Because I'm sure we practice in Sharjah, and then lots and lots of kids come just for medication refill in our clinic. What is your practice?
Really, I think I agree totally with Dr. Arif Khan. Okay, unless I have the chance to evaluate the patient, or at least, for instance, there's some patient with, especially in COVID-19 nowadays, because they are followed up in Tawam or in Khalifa Hospital, and they have medical report by our colleagues, and that we know them. It's okay. And these patients, they are on medications. We will not just simply refill the medication. Yeah.
Thank you. And I agree with both of you. And for the pediatricians who are listening to our talk, it's very important when the child comes to us, and it is your patient who's coming for medication refill, please pick up a phone and call us, and then we will be able to help these kids. Dr. Mackey, while you're there, so who should take the responsibility for these antipsychotic drugs? For example, this child is on olanzapine. I mean, I've never prescribed olanzapine in my practice. What do you think is who takes the responsibility for these medications?
I think simply that is for the prescriber, and usually I will leave that for my colleagues, the pediatric psychiatrist.
Sorry to interrupt, Dr. Mohammed Mekki, if you can just talk but closer to the system.
Okay. Thank you, Tawfiq. I hope just now you are hearing me well.
That's better.
Okay. So just my answer to Dr. Aman's help is usually the responsibility of the antipsychotic medications solely depends upon the prescriber, and usually these are the pediatric psychiatrists actually.
That's right. Yeah. That's right. Vivek, any comments on that? What do you think? What about these antipsychotic drugs on your child? What happened then?
I mean, I completely agree, because I'm not an expert or, first of all, I don't know the reason why she's on this medication. And secondly, I can't decide on the dose, there is any changes needed, and how long should we prescribe, This primary responsibility should be taken by psychiatrists, to be honest. I'm not expert.
Arif wants to comment something there.
For me, it's slightly different, Aman. It depends on your competency. For example, myself, I've gone through a 6 months training through your CCT doing child psychiatry. So I personally have a lot of experience working with children in the autism spectrum who are on antipsychotic medication. So I do prescribe many of these. Even olanzapine I've prescribed a few times. And that builds up with your experience. However, if you've got a child for the first time on a drug like this and you've never used it before, it's completely advisable not to interfere with that and send to a psychiatrist. And when I get stuck with the first, second, or third line drug with antipsychotics, I do refer to a child psychiatrist, obviously.
So I agree with all three of you. So people who are listening to the talk, it's very important that antipsychotic drugs are not just simple over-the-counter drugs. They can have severe, significant side effects. So either you're experienced to kind of treat children with these, on these medications, or if you're not sure, send it to somebody who actually is expert on this, who understands these. Vivek, carry on, please.
Right, so just a comment on her current motor skill, because of course I wanted to examine her and get to know her background. So she was able to walk short distance when she was unassisted, but most of the time she was in her wheelchair. There was no any splint or orthotic support. Hand movements were literally, nothing purposeful. She was mostly dependent. The scale we use called gross motor function classification scale. I'm not going to go in detail, but that she was on grade 4. And communication-wise, she could not even express her needs. In terms of development, just a background, she sat at normal age, like 6 months of age. She was able to stand by 1 year, was able to walk by 18 months. So I guess, everything was normal by then. Behavioral issues were noticed. That was the onset of a problem by 3 years of age, as she was very aggressive with impaired sleep. And I guess most of these antipsychotic medications mainly were for the behavior asset. Then she started, having some issues with the motor skill because the running and walking started getting affected. Parents were not sure. They said maybe because she started becoming more and more stiff. The speech was affected mainly with the clarity, although she was able to say a few words in the beginning.
So this is interesting case, Dr. Vivek, and I will put the question forward to both of my colleagues there. So we have a girl who actually was developing quite well in the beginning, sitting at 6 months, walking by 18 months, so reasonable development. And then suddenly at like 2 or 3 years of age, she started losing skills. Dr. Arif, is there anything specific you would like to know more in the history to try and understand what is our thought process as neurologists when we see something like this?
Absolutely. I'll go back, reverse to her antenatal, natal, and postnatal history. And that's the key here. And then I would also ask for a detailed family history and the consanguinity. I mean, this is the core, the basics that I would need to know first. Yeah.
Dr. Mekki, any more comments on this? Anything else you would like to know?
I think also I will dig deep in the developmental history. I know it's important. I mean, being a girl with this developmental regression, I think I will be fond of knowing certain things related to this gender. For instance, I will ask specifically if she has something like hand mannerisms or something like that. Yeah.
Very good. So the essence here is that for people who are listening is the history. I mean, neurologists don't have any magic. We only rely on a proper history. My boss who trained me used to say that the top 3 things in pediatric neurology you need to know is history, history, history. And all 4 of us here will agree with that. So that's very important that you take a good history going back. Please carry on, Dr. Vivek.
Okay, so as Dr. Arif has correctly mentioned, I wanted to know the birth, perinatal, and other histories. So she was born following a normal pregnancy. All antenatal scans were normal, though she was born by emergency section. Good upgas were there, no any resuscitation needed. She was not admitted in intensive care unit after the birth. Nothing significant in family history as such. In terms of the progress, as I said, the development milestone, but the stagnation was there after a couple of years. In last few years, when I asked, parents said that she completely lost her ambulation, and as I mentioned earlier, she was in wheelchair most of the time. The limbs were getting more and more stiff. She keeps looking at her hands, and that was my observation in the clinic as well. There was absolutely no speech, no motor speech, and no receptive speech as well. Cognition was grossly affected. There was also associated drooling and some oromotor incoordination. She was losing weight. There was possible history of aspiration. And she was doing some repetitive hand movements in the clinic as well. I just want to go through the epilepsy part because I said she came to me as a cerebral palsy and epilepsy. So the first seizure she had was when she was 2.5 years old. She had roughly 2 types of seizure. The type 1 was mostly in the night, and they were with the description like generalized tonic-clonic seizures. And type 2 with the history, she just simply stretches her limbs and she looks like in pain in those seizures. And they are variable in duration, occurs anytime, mostly when she is in distress. And the frequency of these seizures, the type 2 seizures, they're once in 3 to 5 days. But again, as I said, they were variable, not kind of fixed pattern to that.
So this is interesting. So you've been referred a child with seizures, and I am not too sure whether the type 2 is actually a seizure. The first one is very clear semiology. Dr. Mekki, what do you make of these limb stretching movements? What do you think this could be?
Yeah, this might be simply like mannerisms. Okay, they might be like mannerisms. They might be through seizures. Okay. Actually,
So your voice cut off.
it's like very, unless I have like videos or I have this.
That's right. That's right. Dr. Arif, what do you make of these? What do you think? What could this all be apart from seizures? Sorry, Dr. Mohammed Mekki got cut off for a second.
So when I come across a child with intermittent or paroxysmal stiffening episodes, there are likely the two possibilities which are most common. One is it's a seizure, which is a tonic seizure. And the second one is a dystonic posturing that we see in a lot of kids who have neurodevelopmental disorders like this. So if you know how to differentiate the two, you will get to the bottom of it.
Vivek, any comments on these? So dystonic posturing, seizures, and behavioral, anything else you think this could, I mean, this is what you're thinking?
Absolutely. I mean, that was in my mind because of the background of the child. And as I said, the kind of dystonia she used to have. So whether or not, I mean, sometimes it can be difficult to differentiate between a tonic seizure and, dystonic postures. And that's what I did. I asked them for the video. In fact, I admitted this child for 24 hours just to see what these moments are. And with the semiology and with the observation, I think one can make out.
And this is a kind of a thing which I always say to pediatricians. If you're not sure, just video it. So history, and add a video to it now as well.
Absolutely. Thank you. So on examination, there were no any dysmorphic features, there were no any neurocutaneous markers, but as I said, she had severe dystonia, mostly affecting all her limbs. And she has evidence of spasticity in all her limbs, mostly in the lower limbs. There was some contracture in the elbow, again, because of the poor care or no physiotherapy there. Head circumference was normal. There was no any eye contact or no any form of communication as such, verbal, non-verbal. And she had some, as I mentioned, involuntary movements of the hand. I'm afraid I don't have the video because parents, I asked for that, but they didn't provide me the video for that. So again, this is the essence I just wanted to go through, whether or not, she was presented to me as a cerebral palsy child, established diagnosis for last 13 years or so with epilepsy. And with this history, I was kind of clueless, should I call her cerebral palsy and move on? Or are we looking onto something? And based on the history, I just wanted to get opinions. What do we think? Shall I move on, Dr. Aman?
Yeah, carry on. Yes, just go to the next slide.
So cerebral palsy is just showing the definition. It's a disorder of movement and posture. And it's a permanent, but not unchanging. It's a kind of a permanent insult to the motor area of the brain. And it's a non-progressive lesion. And I've just highlighted and made the things bold, which are of significance. And it happens during the brain is developed or in the mature brain. So you have to have certain things. The insult should be in the immature or developing brain. It has to affect the motor area and it has to affect the movement and posture. If you just have seizures, then also it is not cerebral palsy. And the lesion has to be permanent or unchanging. Here in her case, the question is whether we had any evidence to call her as a case of cerebral palsy, depending on the history, of course, considering the normal antenatal, perinatal event and no such history suggestive of any insult to the developing brain.
So, gentlemen, here's the thing that we have a child who has got no significant history, who is diagnosed as cerebral palsy, was developing normally and then regressed, apparently. What would you think quickly in terms of investigations, because we are running out of time here. Dr. Mekki, what investigations would you like to do here to come to a diagnosis?
I think I will start with neuroimaging.
Okay. And what will that help you with?
With this type of, clear regression, that it might give me clues about how I'm going to proceed. Okay. So the imaging, might give some clues about possible differential diagnosis with this query regressive type of condition.
That's right. So I agree with you, because if you do an MRI scan, people have labeled the child with cerebral palsy. You want to look at any hypoxic ischemic insult, any periventricular leukomalacia. Neuroimaging is going to help you with that to come to diagnosis. Arif, anything else you would like to do?
No, so from the history, it's very clear that this is a neuroregression process going on. So when we talk about neurodegenerative condition, some of them are treatable. So we need to find the cause. And I agree that the first step is to get neuroimaging done, and that will give you a big clue, of course. But sometimes we as neurologists and some pediatricians, we come across cases like this where we have one or two handles where the penny drops. And in that case, we jump on straight to more specific diagnosis. I will probably, that's my thought process. But maybe after this, we will go on to do some metabolic testing to rule out the common neurodegenerative conditions, and maybe moving on then to some other test looking at genetics and so forth. Yeah.
So in this particular case, Arif, is there any handle which is going through your mind? Anything particularly which you think is going on, as in a specific clinical handle?
Yeah, so two or three of them. One is regression between 2 to 4 years of age with a child who was developing near normally in the first 2 years. And two, the hand wringing movements, the hand function, losing the hand function is a very key as well. So these two handles just directs me towards a specific diagnosis, which we can get an answer of looking at that specific investigation.
Lovely. Moving on.
Female child as well.
Yeah, female child.
Yeah. So MRI brain, as Dr. Mekki said, was repeated. It was normal. We had, because the muscles were involved, just to look at the CK, lactate, EMG, nerve conduction study. Of course, EEG had to be abnormal, but it was just multifocal changes. We did metabolic staining, as Dr. Arif said, it was normal. So everything as
pretty much normal.
We discussed, it's normal.
Okay, so Arif has already touched on it, that if the MRI scan is normal, metabolic screening is coming as normal, you're going to think about neurogenetic condition. And I think Dr. Arif has already mentioned 2 or 3 very important handles, and Dr. Vivek has also mentioned one. So I will carry on, Dr. Vivek.
Yeah, I think we've pretty much come to that conclusion that we would go for a genetic testing. We did clinical exome sequencing, and this is what we found. This child had pathogenic mutation in a gene called MSCP2. Those, I mean, I'm sure this is a very common gene even for the pediatrician, and this condition is called Rett syndrome. So just briefly on one slide on Rett syndrome, it's a very rare genetic disorder, almost exclusively affects the girls.
Dr. Vivek,
sorry
to disturb. Like your mic, if you can keep a bit closer to your mouth.
Okay, yeah. So the Rett syndrome, as I said, is a genetic condition, almost exclusively affects the girls. It has 4 stages of development. There's a normal growth initially for around 1 year or so. Then there's a stagnation, there's a kind of a plateau where the child loses mainly the communication skills, any lack of interest. And these kind of hand movements or jerky limb movements are very typical or peculiar in Rett syndrome. And followed by that, there's a regression of communication, cognition. There are a lot of autistic features. There are lots of purposeful hand movements with wriggling and tapping movements. And that plateau is then followed by deterioration in the motor skill. The child can have spasticity and dystonia, mostly affecting the motor skills, scoliosis and loss of ambulation. So that's the typical history of Rett syndrome. Right,
okay, so,
over to Dr. Aman.
Thank you. Thank you, Dr. Vivek. So, and thank you for the panel to come to the diagnosis as well. I think you were thinking on the right terms. In terms of quick questions now for the people. So which of the following is not true for cerebral palsy? I know you've gone through the discussion. Dr. Vivek, can you go back to your slide again, please? Just share the screen, full screen, please.
Okay, yeah.
Share the full screen. Thank you. And go to the next slide. And the next one. So question number 1 for you, which of the following is not true for CP? It's a disorder of movement and posture and of motor function. It is permanent, but not unchanging. Children with hypotonia as a sole neurological finding can be labeled as CP. Label should be in quote, unquote, and it is due to a non-progressive interference lesion or abnormality. So see what you think, guys, and then just put your poll there. And I think I will have the poll result with me as well in a second. Okay, next one, please.
No, the poll is on.
Ah, the poll is on, okay. So
we have to wait.
Yeah,
oh, you have to wait. So, okay, sorry.
Yeah, 30 seconds.
Tawfiq, just tell me when to move on.
Yeah, please.
Okay, the second question, which of the following is features of Rett syndrome? Dr. Vivek and Dr. Arif and Dr. Mekhi has told you many of them. It's almost exclusively seen in girls. I've put the word almost because some boys, sorry, I shouldn't be saying that. Development stagnation after a period of normal development. Microcephaly on clinical examination. Hand wringing movements, very commonly they keep doing that. And or is it all the above?
Okay, so you got the first poll answers, Doctor.
That's now like 54% is number 3.
Yes, and that is the correct answer. So if you have just hypotonia, please don't get sucked into call it cerebral palsy. It can be lots of other things. So whenever somebody comes with hypotonic CP to me, I always get concerned.
The second one is not yet appeared, Tawfiq. Now.
Vivek, can you please come off your screen? So I'll ask Dr. Arif to come on share screen quickly.
The second question is on now, doctor. Can you answer?
Yes, poll is on.
Yeah, so the answer to that question is all the above.
Yes.
Remember all the features. If you see any girl, baby girl who is started to regress after 6 months or 1 year of age because they develop normally in the beginning, they have small head circumference, they have seizures, it is going to most likely be looking at Rett syndrome. So refer them on quickly. Dr. Arif, house is yours.
Share my screen.
So we quickly go to this case number 2 now, which is also a very common scenario, which we see as pediatric neurologists. And I'm sure as pediatricians, you also come across this very commonly.
I think Dr. Aman gave the answer before the poll results.
Sorry. Next time, just tell me, Dr. Kalpana, that I will not get the answer.
Anyway, 63% still. So yeah, some didn't get it right.
Majority got it right. That's good.
83%.
83%. Very good.
83. Okay, 83.
Well done.
Aman, can you hear me?
Yes, please go ahead.
Can you see the screen?
Yes.
Okay, great. Right, I'll start off with case 2. Start moving. Give me a second. Right, so the history goes like this. This is a 15-year-old girl who's been complaining of headaches worsening for 3 weeks. So obviously it's progressive. She was previously fit and well, and she complains of a constant pounding headache, which is diffuse all over the head. And 2 days prior to seeing me, she developed blurred vision. There was no photo or phonophobia. There was no nausea or vomiting. And there was no history of recent illness, either cough, fever, or any travel. So I took up a quick examination, and she was in moderate discomfort, was tending to lean on her mom. Higher motor functions were absolutely normal. She had normal cranial nerve examination, except one of them, which I'll discuss later. Pupils were normal, no meningeal signs. Other neurological examination, including tone power and reflexes, were normal. No cerebellar signs, no dysmetria. Sensory system was absolutely normal and normal gait.
Okay, so let me start with my colleagues here. I'll start with Dr. Vivek because he was sitting there doing the talk before. Now it's time to answer some questions. So if you see a child, let's say 6 or 7-year-old child, which comes with blurred vision to you in the clinic, what is your thought process behind what could be going on in here?
I think it depends because it's the acute onset. So there are a couple of things going in my mind. First could be structural causes, any space occupying lesions, again affecting the optic tract. Secondly, it could be still infective. I would still like to, get the history if there's any history of encephalitic features, fever, and all sort of things. Or vascular is another cause, whether there could be any vascular event. And autoimmune, because again, demyelination in certain places can be presented with the loss of vision. So of course, ophthalmological examination will play a crucial role in that. But those are my differential diagnoses to start with.
Spot on, Dr. Vivek. So painless blurred vision. So Dr. Mekhi, anything else? So Dr. Vivek has just mentioned some demyelinating conditions. So if a girl or boy comes with painless blurred vision or loss of vision, what are the autoimmune conditions you are thinking about?
Of course, we have the demyelinating disorders. These are a big group that we need to think about. Something like optic neuritis type of condition.
That's right.
Yeah, so, okay, this is one of the things that we need to think about. Actually, kids labeled to be like poor historian. Okay, again, history is very important. We know we have like many congenital things that also might appear. So I think family history also is well is important. But I think I agree most of the conditions mentioned by Dr. Vivek we need to think about. Okay, in view of this very short acute history, I think certain conditions like related to race, integrated behavior also need to be considered. I think this most of the
Mackey's screen is very hazy.
Dr. Mekki, the last bit we could not hear you. The last bit.
Dr. Mackey's screen is very hazy. Dr. Mackey's screen is.
So I'll just interject this. Sorry, Dr. Mohammed Mekki. I just lost the last bit, but I got the gist of what you were saying. So if a child comes with blurred vision, which is painless, acute, it's always a cause of concern, has to be referred to the right kind of team. Dr. Vivek, any clinical findings you are most interested in a child who comes with such a feature?
I think, as I said, mostly the ophthalmological examination will play a crucial role. Whether there's any optic neuritis like findings or papilledema like finding, and of course a thorough general examination, because he mentioned something about the cranial nerve examination as well. Any extra ocular muscle involvement in that might give us a clue as well. But yeah, as I said, thorough ophthalmological evaluation to start with.
So all the pediatricians listening to this talk, remember to look at the fundi of every case. That is how you will learn to look at the fundi. When we were training as pediatricians, our bosses used to say, even if a child comes with asthma, go and look into the eyes. Only then you will know what is the proper right disc, which is the normal disc, and which is the abnormal disc. So please look at the fundi. Moving on, please, Dr. Arif.
So we went on to the examination findings, and I'll just list the key examination findings here. The first one was the extraocular muscles. She could not completely abduct her left eye. And if she did so, she had diplopia on left lateral gaze. The visual fields were carried out by the ophthalmologist, who was pretty handy and in my next clinic next to me. He said the blind spot was pretty enlarged. And on fundus examination, it was clear that there was obscuration of the margins, elevation of the disc margins as well, an absence of any venous pulsations, and some tortuosity was seen in the vessels bilaterally.
So this is interesting because we have a kid who's got some blurring of the discs, loss of venous pulsation. Dr. Vivek, what do you think is one of the, what I can understand from Dr. Arif's talk here, he's talking about papilledema here because there is disc swelling is there. There is loss of pulsations, but many a times we get patients referred to us with disc edema or papilledema, and yet there is no symptom. There's no headache. The child looks very well. So what is that condition which we should always remember that we should not confuse with papilledema?
Yeah. So one of the commonest thing is drusen, and again I was caught one in Great Ormond State again. There was a congenital.
We all have.
Yeah, so drusen is one of the most common things.
Yeah. So for the people who are listening, I have seen cases who had lumbar punctures done because of papilledema, but ultimately they found out to have optic nerve drusen. So please make sure that the ophthalmologist who is seeing this patient or the child is experienced enough to have done pediatric ophthalmology. Dr. Mohammed Mekki. So this is that, Dr. Arif, can you go back one slide again? So as you can see, there is a diplopia on the left lateral gaze here. So what do you think is going on in here?
I hope that you are hearing me well. I think I have a problem with my connection.
I can hear you now, yes.
Okay, that's fine. Okay. So just let me add to the first comment of the optic nerve drusen, actually.
Yes, go on, please.
I think usually when it comes to with in my previous maybe 2-3 months, I have seen like 2 patients referred from the ophthalmology department because of drusen, actually. It's okay because of papilledema, but it's mainly the patients that don't have any complaints, they don't have any concerns. Okay, so this is one of the things that we see commonly in our practice. Okay, so back to your questions. Actually, most likely that, I think your question about the left lateral gaze
Yes.
problems, is that right?
Yes.
So it's most likely that is the abducens nerve is affected here. And abducens nerve is a very long nerve and usually caught in any cause of raised intracranial pressure because of the cause.
Yes.
So this is
Very good. That's right. Dr. Arif, moving on, please. One slide more.
Yeah.
So I agree with you, Dr. Mekki, that the sixth nerve is involved here, and which is the most commonest nerve involved when we have some sort of raised pressure or any problem in the brain itself. Because as you rightly said, it's one of the longest nerves, and that's a question we remember from our medical school days. Please carry on, Dr. Arif.
So clearly the child had two significant signs. The first one was papilledema. And I think when we get positive signs, we need to understand why they are happening, and not just in neurology, but in any field. So clearly the papilledema here is probably because of raised intracranial pressure. Now that could be because of multiple reasons. The left sixth nerve palsy, as we discussed, it's what we used to be taught as a false localizing sign or non-specific sign, suggesting that any raised intracranial pressure can give rise to a unilateral sixth nerve palsy. Why does it happen? As my colleagues have said here, you have increased pressure in the brain intracranially, and your brainstem is pushed down. The sixth nerve that comes out of the back of the brainstem is compressed, and you have this. The third point is enlarged blind spot. Why does that happen? And that's purely down to the retinal cells which are surrounding the optic disc. And because the optic disc is under pressure, the cells around it undergo degeneration, and it leads to enlarged blind spot. The fourth one, why do headaches happen in children with increased pressure? And that's purely down to displacement or movement of intracranial pain structures, which could be the dural and cerebral arteries or venous sinuses. So now we know each of the symptom, why it would have given rise to that. And as we were talking about papilledema, I think it's a good time to just look at the 4 stages. I'm not going to go into the details of this, but for a complete novice who wants to develop the skill to look at papilledema, as Dr. Aman said, we need to see a lot of normals. We need to see a lot of children that have normal funduses. And I see children above 8 who are cooperative, and I try to learn what a normal fundus looks like. So the first top left one here, and I remember only 3 signs. There are more than 9 different signs, but I'm not an ophthalmologist. I'm a mere neurologist. So I'll look at 3 signs. So if you look at the top left image there, it has very crisp margin. It has a very orangey color to it, and the vessels are very clear, and they are pulsatile, if you see a live video of that. So there are 3 signs, remember. As we move on to the top right one, you see the margins are slightly blurred, but the vessels are fine and the color is okay. If you go on to the left bottom one, the margins are completely ragged. You cannot make out any margin there. The fundus itself is very pale, and the vessels start losing their continuity. And of course, if you look at a live picture, live video, the pulsation will not be there. And look at the last one on the top, on the bottom right, you can start seeing some hemorrhages coming in. So of course, these are different stages of the papilledema, but I remember 3 signs, and I look for these 3 signs in every child with a normal fundus, and that's how you will pick up an abnormal one.
True. Okay, Dr. Mekki seems to have disconnected there somewhere. Okay, so
I'm here now.
Oh, you're here now. Yes.
Yes, sorry.
I'll start with Dr. Vivek. So, Dr. Vivek, you have a child here who's got papilledema, who's got left sixth nerve palsy, probably because of raised ICP. What are your top 3 differential diagnoses? That's a question. This is your MRCPCH now.
I think again, acute onset of papilledema, I must rule out space occupying lesion.
Yeah.
Of course, the child, Dr. Arif didn't mention about vomiting or any other sign, but that's still the top of the list.
Absolutely.
I would still like to rule that out with neuroimaging. Again, as I said, vascular, again, sinus venous thrombosis can present with papilledema, headache-like features. And if you rule out everything, then probably benign intracranial hypertension is something, because the child has headache and papilledema. But of course, if I rule out all these things first.
Correct. Dr. Mekki, so what investigations would you like to do in a child who comes to you with headache or papilledema and you worry about raised ICP? How would you proceed? I know we all do neuroimaging. That's what we do all the time. But anything else as a package you would like to do?
I think an urgent CT with contrast is a must here. Okay.
Neuroimaging. Yeah, that's right. To rule out brain tumors, as Dr. Vivek said, you're right.
Yes. Okay. And I think after that, I think that's supposed to be followed with contrasted MRIs, especially with MRV. I think this is very important. And of course, after these two investigations, I will proceed to do an LP to measure the opening pressure. And of course, if I'm thinking about the basic intracranial hypertension, I mean also the routine, because that is a diagnosis by exclusion. So I need to exclude still infection. So I think these are the three investigations that need to be done.
Correct. So people who are listening to the talk, I think you probably already got the gist of what's going on. But one word of caution here: if you see a young girl or a teenage girl, or teenage boys, mostly girls, and raise ICP you are suspecting by papilledema, do not forget to do venogram. MR venogram for sinus venous thrombosis must be done, should be done. It's a part of your investigation when you're looking for raised ICP. Arif, please carry on.
So as Vivek said, we're looking at differential diagnosis. And obviously, although I knew this child is probably heading towards idiopathic intracranial hypertension, for many of you, it's not called benign anymore. It's idiopathic, because we know many a times these condition, it doesn't turn out to be benign, and it can cause serious damage. So it's called idiopathic intracranial hypertension, or IIH. But I cannot assume that, so I have to rule out many other secondary conditions. So hydrocephalus from a tumor can give you the symptoms, meningitis, but clearly in this child, there were no signs of infection. Migraine usually doesn't give you papilledema, but that's something to think about. Subdural hematomas and slowly progressive bleeds in the brain can give rise to this, but they will also have other neurological signs and symptoms. Investigations. Now, I'll just take probably a minute on this. So if I am in an emergency unit and I have to scan the child immediately with these symptoms, I would do a CT with and without contrast. However, if I'm in an outpatient department and it's a teenager, I would straight go for an MRI brain, again, with or without contrast. But as Aman said, do not forget MRV. Although an MRI can give you a good idea about the venous structure, you should always get a formal MRV done. Point number 3, we would go ahead, if the MRI is normal, of course, doing a lumbar puncture. And I'm sure all the pediatricians here know that a normal pressure is anything less than 25 centimeters of water. Blood test, in this particular case, I didn't go ahead and do a big profile. I just went ahead and did some basic tests like ANAs, parathyroid levels, and CBC. You should always ask for the medications the child is on. So there could be secondary causes for raised pressure. And I have come across few cases where the kids were taking retinoic acid for acne, growth hormone supplements, and of course, steroids. They are the usual culprits that can give rise to the raised pressure. So remember these 5 possible drugs that can lead to secondary IIH. And then of course, ophthalmological examination, which I consider as a part of my investigation. And I ask the ophthalmologist to please carry out a visual field testing. Many a times the kids are sent back to us without a perimetry or visual field testing. I think it's important for you to emphasize that when you send out a referral. So what I've just shown here are 3 pictures. The one on the left is something called as an OCT, okay, an oculo-computed tomography. This is a good test for someone to identify whether this is a drusen, that means a congenital swelling of the disc, which does not require any treatment, or it is a papilledema. And this, in the hands of the right neuro-ophthalmologist or a pediatric ophthalmologist, will give you an answer. We have seen, and I'm sure Aman, Vivek, and Dr. Mekki would know, we have saved a lot of children undergoing invasive lumbar puncture testing by just asking a pediatric ophthalmologist to give a second opinion on a diagnosis that has been made. So you can see the top one here on the left, this one here. It's basically showing a thickened retinal layer, and this is a child with papilledema, and after the treatment has been started, it slowly flattens out. So we don't need to know about this in detail, but just for your information. Then of course, the MRI is essentially normal in children with IIH, but there are some subtle signs that sometimes help you identify true IIHs. So you can see the red arrow, which shows the optic nerve's tortuosity, that will be increased. And the blue arrow here showing the area around the nerve, which is called the perioptic area, it is enlarged. That's obviously because of the CSF pressure. The white layers around the optic nerve tell you that the subarachnoid space has been enlarged. And the flattening of the disc or the sclera, as you can see here, usually you find a small bump here, but it has been flattened. So these three signs you look out for when you see an MRI for a child with IIH. And of course, we have to carry out the manometry. It's very surprising and quite astonishing to me when I hear that many of the hospitals do not even have a kit for doing manometry testing. And I would urge every pediatrician who's listening to this to go on a Sunday, if you're working on Saturday, go on a Saturday to your management and say, can we have some of these manometry kits with us? Because you might need 1 or 2 a year, but please keep it because that will save a lot of hassle if the patient comes to you. Moving on to treatment. Aman, I'm very slow, or is that a good pace?
I think we need to wrap it up now. So let's go to the quick treatment bit.
Only 3 minutes, please. We have a question and answer and with prayer time also. Thank you.
All right. So treatment, moving on straight. When we do a spinal tap, we have a question at the end. We need to know how much fluid to take out. But I always tell parents to make sure the weight loss program is in place. Any causative medication has to be stopped. And the drug we use is acetazolamide. If the child is not responsive, we sometimes add furosemide. And if the child is not responsive, then we could use topiramate, which is also an appetite suppressant. So these are some of the tools that we have to help reduce the pressure. In very severe cases where there is impending visual loss, we do tend to use steroids. And in very severe cases, we also get some ophthalmic surgeons that are involved to do optic nerve fenestration or CSF shunting, but that's extremely rare.
Okay, let's go to the questions quickly now. So Arif, can you go to the next slide, please? So quick question, when was the last time you did the lumbar puncture for a suspected IIH case? Was it last week? Was it 6 months ago? Was it in the last 5 years? Or I have never done this in my life? Dr. Shora,
The poll is on.
Tell me when to go to the next slide, please. Just prompt us.
So the poll is on, doctor.
Okay.
I'll just tell you 20 more seconds to close the poll.
Tawfiq, let's give them only 10 seconds. While this is going on, Dr. Mekki, just be prepared that you only have 10 minutes.
So never 69%.
Okay, good.
Last 5 years, 25%.
Yeah.
Last week, 6%. Last 6 months, 0.
So there you go. So it is it needs a little bit of practice and also supervision and confidence to do it as well. And plus, you should have equipment in your places. Next, please. Next, Arif. So the answer is there already. That's okay. Let's go to the next one. So how much spinal fluid do you want to withdraw? The answer is to bring it down by 20 centimeter of water, but the maximum the maximum should be 20 ml. Do not withdraw more than 20 ml because that can be detrimental to the child. You might reduce the pressure too much and give the child side effects. So be careful that the ml should also be 20. So this is the answer is already there. Arif, that's the only questions, right? Okay, treatment for IIH. This is a question which I had put there as well, but the answer is also in red, so you have the answer. How long do you continue treatment for IIH? It actually varies from child to child. But in our experience, most of the children, we treat them for about 6 months. And ophthalmology check is done every 4 to 6 weeks to make sure they're getting better. In my experience, by about 6 months time, everything settles down most of the times. Thank you, Arif. Dr. Mekki, quickly, 10 minutes you have, sir. I'm so sorry.
Okay, fine. Just please, Dr. Arif can quit. Yes, thank you. It tells me that I can't share my screen because somebody is sharing his screen. Yes.
There you go. It's yours now.
It is prayer time. We would like to request you to go a little faster. Question and answer time is also there.
Dr. Mekki is just trying to put his slides there, Dr. Shora, as you can see. There you go. Fantastic. Please go ahead.
Okay, I'm just gonna make it like it's a hurry. Yeah. Thank you again for giving me this opportunity. So I'm gonna present a 7-year-old girl transferred from General Hospital in Sharjah for unexplained acute encephalopathy with rapid deterioration, and she lost her consciousness within hours. She was well and playing with her friends, and suddenly she had this complaint in addition to feeling dizzy, and she vomited repetitively. Okay. So, no history of headache, irritability, fever, or respiratory illness. She has no recent vaccinations. Also, there is no history of, there is no significant birth history, and there is no significant family history of coagulations, connective tissue disease, or.
Just 2 questions, Dr. Kalpana. One you will ask, one I will ask, because prayer time is here. Mr. Tawfiq has to announce the.
So, next one, Dr. Mekki, yes, please. So, guys, I will skip the first question. I will just go to the differentials bit. So you have a girl who was vomiting, she felt dizzy, and she collapsed. Vivek, what do you think? What could be this in terms of in your thought process?
In acute onset could be infective. Another, because for her age and all, it could be still autoimmune like an MDA, and probably stroke, vascular etiologies.
Stroke is there, yes. It could be infectious. Arif, what else could it be there? A girl who's suddenly vomited, felt dizzy, collapsed. What else could it be?
Could be epileptic as well. That's something we need to think about. Epileptic. It could be an epilepsy.
Yes, it could be a seizure as well. So it could be a seizure, it could be infection, it could be a vascular event. Very good. Moving on, Dr. Mekki.
So her initial workup was normal, included liver profile, renal profile, blood chemistry, blood gas, septic screen, and uncontrasted CT pain. So further management given in the hospital before to be referred to us. She was started empirically on ceftriaxone and acyclovir, and of course she was admitted to the ICU because of sudden desaturations with intubation and ventilation. Actually, next day we referred to our hospital. Her GCS was improved 11 to 15. Her deep tender reflexes were absent in lower limbs, but decreased in the upper. Her power grading 2/5 in all her limbs. She has normal fundoscopic examination. Her CCF studies done, of course, after the imaging tend to be normal, and her urine and drug toxicology screen was negative.
Okay, so guys, start with Arif first. So we've got a child who suddenly collapsed, dizzy, vomiting, and now also has got loss of power in the legs. What investigations are you thinking to do on this child now?
So clearly, the initial investigations have been already listed out, but I would also do a neuroimaging at this stage. As usual, as neurologists, we do an MRI, but I would also include MRI spine because the weakness of the lower limb, and then move on to do specific investigations looking for, NCS, looking for nerve conduction and all that. Yeah.
Okay, so we're thinking about an AIDP kind of picture here because of the loss of weakness. So Dr. Vivek, we've got an MRI scan. I'm just going to move swiftly. Dr. Arif mentioned MRI. Is there anything else you will be thinking or doing along with the MRI?
I might consider with contrast in certain stages just to make sure there's no demyelination. Plus vascular, we discussed about vascular etiology, so maybe MRA could be included in the other part of, or the CT angiogram, whatever is the investigation.
That's right. That's right. Good. So angiogram and maybe even venogram to add with it because there's a certain loss of tone. Carry on, Dr. Mekki.
So as my colleague mentioned, we did MRI brain, and actually her previous MRI brain was reviewed by our neuroradiologist, and she showed that ischemic insult to suspicion of posterior craniocervical.
Sorry, Dr. Mekki, can you show us the picture straight away? And then you can explain to us. There you go.
I know for the time constraint. As you see, you can see the flare and you can see the T2. I mean T2 and T2 flare. I know the quality of MX is not so good, but you can see that there is increased signal intensity, especially in the left part of the medulla paramedially, and you can clearly see here the high signal intensity as seen in the T2. And moving on to DWI, you can see more clearly the high signal intensity, and that's confirmed with the ABCB map. Okay, so all that confirms this patient, she has, at least in this area, that she has medulla oblongata infarctions. Okay, and here, as you can see, there is intimal flap. This is very clearly in the vertebral artery as well.
That's right.
Okay. So further history in light of these suspicions, actually, because the family didn't volunteer to give a history of trauma, this was clearly after just taking another history from the family, that's clear history of trauma. And of course, we make the diagnosis of vertebral artery dissections, and she commenced on aspirin and discontinued the ceftriaxone and acyclovir, and she went to a rehab plan, and patient currently, she has a satisfactory improvement. Okay.
So just going back a bit, Dr. Mekki. So it's interesting that, the next slide, please. So it's very interesting that you've done a child who's actually collapsed. You found vertebral artery dissection in there, and you started on aspirin. So my colleagues here, when something like this happens and you see that the posterior circulation is affected, what is going through your mind? That history is very important, obviously, and you've got dissection going on, and this child was started on aspirin. Anything else you would like to do along with aspirin if you have to? Is there anything else, Dr. Arif?
Anticoagulation is always a question that we answer, but as much as possible in children, we tend to avoid that, and especially in very young ones. But I would obviously take an opinion of my vascular colleague to understand what would be the best way forward. But usually, at least in this case, I wouldn't have considered anticoagulation, and I would agree with what Dr. Mekki carried out as treatment.
Vivek, anything?
Just going a little bit out of the track, because there are cases of spontaneous dissection which happens in autoimmune vasculitis-like cases. So it's one of the things. I've seen a child with vigorous coughing and having this thing. So these things out of the box has to be considered if, let's say, you don't find an obvious cause. And of course, carotid and cardiac examination comes into picture whenever you.
Very good. So yeah, cardiac examination is very important. And for people who are listening, when you see a stroke, the take-home message should be always image their neck vessels. So people do MR angiogram and they just do the brain vessels. They forget that there can be a problem in the neck. And carotid drop Dopplers will only help to look at the carotids, not the vertebral artery. So you must think about MRA of the neck vessels as well. Moving on, Dr. Mekki.
Yes. So just a few words about vertebral artery dissections. Infrequently and commonly overlooked, actually. And of course, it occurs due to tearing intimal layer after trauma. But as Dr. Vivek said, it might happen spontaneously. And of course, cervical artery dissections is less common in pediatrics compared to the adult. And usually we see in practice, actually, I'm quite sure all of we as pediatric neurologists, we see like very few cases of vertebral artery dissections, but if that happens, usually after trauma, and it's more common in the male compared to females. I think this is the end of my talk, and thank you very much for the listening.
One more trivia thing for people, thank you, Dr. Mekki, is that if you go to PubMed and look at the case reports, there's a case of a lady who has got her phone like this, and she's put her neck like this, and she's talking and doing some work, and she was in this position for so long that she ended up having a vertebral artery dissection. So be careful on that too. It can happen spontaneously. Thank you very much, Dr. Mekki. Thank you, Dr. Arif. Thank you, Dr. Vivek. I think that was a really, really good session. And thank you for all your thoughts. Over to Dr. Kalpana and Dr. Shora.
Thank you, Dr. Raman and the panelists. This was really interesting. We have a lot of questions, but because of shortage of time, I think we'll stick to just a couple of them. The first question is to Dr. Arif, a couple of questions to him. In fact, one which he has, I think, already answered, what's the prognosis of a case like he has presented? And the second one, is there any danger of cerebral herniation in such a case with benign intracranial hypertension when we do the LP? So.
Yeah, the answer to the first question is this child was fantastic. The prognosis, for 6 months, we gave treatment. The papilledema resolved and she never had another one. So the good thing that's why it's called benign. It used to be called benign because most of them have fantastic prognosis and they overcome it. In some cases, it has been reported that it can recur later, But for me, most of the cases that I've seen in this part of the world, they haven't come back. Yes, there are some which are very refractory, which do not respond to treatment. In those cases, we escalate treatment and we have to keep going for maybe a few years even, and we have to think about secondary causes more and more. So I had a child with a kind of compression of the vein, the sinus venous thrombosis compression. So a stent had to be put in to enlarge it. So we can go deep into it, but by and large, they are very benign and they respond to treatment very quickly. Yeah.
Just a small question from my side in connection with this is, are these drug-induced cases always after long-term use of these drugs, or when somebody just initiates and a person can still get it?
Even few months. I have seen children using growth hormone, the 8, 9, 10-year-olds who present with IIH early on. So it can happen in few months even.
Right. Dr. Aman, you have brought up certain queries in our mind as far as neuroimaging is concerned in relation to the cases presented. In short, for pediatricians, can you just highlight when would you use CT if you do use in current scenario? I mean, most of the neurologists order MRIs, and you spoke about MRV, MRA, cervical vertebral circulation to be checked. So please, just quickly, if you can highlight it for us.
Okay, so there are 3 different cases here, and all of them have different sort of neuroimaging to be carried out. A CT scan is something which is most commonly used investigation for the pediatrician. So from a pediatrician point of view, if you see a child who comes into your ER or your practice with localizing signs, okay, on examination, and other things like headache and all is always there, the symptoms are there. But if you see any localizing sign, don't be shy of doing a CT scan. My only concern is sometimes when the child comes with a generalized tonic-clonic seizure and they have got a history of epilepsy in the background, they end up doing having CT scans to check for if there's any problem. That is something I
think we lost him.
Dr. Aman, we lost you.
We lost you.
Dr. Vivek or Dr. Khan, you can take the question and answer, please. Continue.
Vivek, please go ahead.
No, I think
explain CT and we can take it
summarize and sorry,
from there.
Aman is here. Yeah.
Yes, Dr. Aman.
Yeah, we lost you in between, Dr. Aman.
Oh, sorry. Where did you lose me? Vivek, you're saying something.
It was
No, you just started with the CT in seizures. You are not happy with that. So,
Yes. So I'll say again. So if a child has a generalized tonic-clonic seizure and also has a previous history of epilepsy, you have a clear history there that this is a GTC with a previous epilepsy history, I would not do a CT scan in that situation because the history is there. But when you're not sure, the child has come with a focal seizure or a focal kind of pathology, I would go ahead and do a plain CT. Or if you have a CT contrast, that's absolutely fine. And then you can speak to your local neurologist that I've done a CT, this is the history, what else I need to do, then we can guide them from there on.
Yeah, and one more thing, I mean, along with neurologists, the neuroradiologists are very helpful. If you're not sure, just discuss with them and get their guidance, because again, they should decide the sequences and things to do. So
that's right.
Another person to come in.
And I think just I add thing here. As Dr. Vivek said, I think because usually the neurology, the department of neurology, even there is no neuroradiologist, usually they are very aware about what to do. So I think just taking the lead and talk to them, that's gonna add many things actually. What you suspect about your patient, I think, and just let the floor for them what to decide, what to do and what not to do. In many cases, even for me, I'm just taking the phone, I'm calling the radiologist on call, I'm telling him the clinical information about the patient, and sometimes even get the guidance, what is the better for this patient. So I think that is like, especially in a country like UNE, and most of the investigations just between 2 brackets are a bit expensive and might not be covered by insurance. So I think that is a very important message to be given to the patient caring for kids with query CNS problems. Yeah.
Right. And Dr. Vivek, about your case, once it is diagnosed as Rett, what is a neurologist going to do then? I mean, is there any particular treatment? Why should there be?
No, but the whole perspective changes even for the parents and the child in terms of the prognostication. What are the things I should be expecting her in future, and what sort of help we should be involved. Yes, you're right. We're not going to change even if she was CPM presents with the same thing, because ultimately she will need physiotherapy, OT, treatment of dystonia, spasticity, But I should bear in mind that things would be regressing over the period of time. The parents are expecting those things. So it's not just about the condition, but the issues which she presents with, including epilepsy and the tone management and orthotic support, everything. But I think things have changed for the parents' point of view. I can tell, they were kind of relieved, saying that, we didn't know about this condition. They started reading about it. They knew what kind of support and what this condition actually is. And that comes as a part of genetic counseling, of course. But I think we have changed the whole perspective for them and for the child.
So I'll add to that, Dr. Vivek. So Dr. Kalpana, just a quick line to that. When we come across children with neurogenetic disorders, you would be surprised how many times a parent tells us in the end that now we know.
Yeah.
Up until now, we did not know what we're dealing with. So although we cannot change the kind of the condition or the situation here, yes, we can manage the child accordingly. But the fact that they know now puts the loop into completes the circle, and hence the reason to do genetic testing.
Sure, thank you. Dr. Saurabh, I think had a question.
Well, and that's the last question, because after this, there is an announcement Tawfiq will give. Because, many children from early childhood, they are, coined as cerebral palsy. And this diagnosis goes to the adulthood and nobody changes. Now, I would like to request you, the panel, give a clue. What are the cases not CP? Everybody puts CP. So what are the cases not to put CP in just nutshell?
Okay, so Vivek, do you have that slide there with you?
No, not sure. Just tell us.
We had a slide which said this is not CP. I actually removed that slide to decrease the. Vivek, if you can just
yeah.
Go ahead, please.
It's not a complete neuro textbook.
Okay.
No, just mention what are the conditions not to think, because everybody is CP.
So while Vivek is doing that, Dr. Saurabh, whenever a child comes to me in my clinic labeled as CP, I don't believe that. Okay, I go through the full story again before I come to the conclusion yes or no. So Dr. Vivek, yeah, go.
We would expect no less from you, Dr. Aman.
So, I had an adult who was diagnosed, as Dr. Saurabh correctly said, to have a CP throughout his life. Just because his son was diagnosed with ATP1A3 mutation, we could, find out the same mutation in the dad and say that he's got a rapid onset dystonia Parkinsonism. But yeah, that's the point. So CP, I had this, can you see my slide? Yeah.
Yes, we can.
So if it is any progressive condition resulting in loss of acquired skill, as this girl I presented has, that is not CP. So you have to bear in mind, if a child is normally developing in the first hand and then start losing the skill, no CP. Any spinal causes causing any motor issues, weakness especially, or paraplegia like things, that's not a CP again, any spinal causes. As Dr. Aman has emphasized, hypotonia presenting alone, there's nothing like hypotonic CP. Yes, ataxic CP can have element of hypotonia, but alone hypotonia, if the child presents with, please bear in mind you're looking for some other causes. And it's actually a phenomenology, it's not something etiology. So many of the cases you might see a normal scan, but you have to look at the perinatal history, the time at the perinatal period. And as I said, it could be a permanent lesion, but not changing, because the child is, of course, developing and growing older.
Dr. Khan, please.
Dr. Saurabh, just a message here. I won't take more than 10 seconds. We are moving towards eradicating the word CP.
Yeah.
Because what that does, it stops people from thinking beyond an umbrella term called CP and not looking at the cause of the problem. So I urge pediatricians here that don't shut the textbook the moment you hear cerebral palsy, because that is not an etiology. It doesn't give you any kind of help with managing that child. It's just an umbrella term for you to relax and say, oh, I've made a diagnosis. Cerebral palsy is not a diagnosis. It's a phenomenology, as Dr. Vivek said. So we always look, if you have a mindset of looking beyond that and trying to find out the cause, yes, it could be a hypoxic ischemic injury at birth, then you're fine. That's a diagnosis, yes. But don't keep it at CP. Try to go beyond that. And then you will find a number of cases which are not CPs and are mimics of CP, which might need a specific treatment to get better.
I think I would like to thank the real panelists. If we go really, they will ask more questions. But Kalpana, please allow me, because after this there is announcement and prayer. I would like to thank Dr. Aman, Dr. Vivek, Dr. Arafan, and Dr. Makki and Dr. Kalpana. So Dr. Kalpana, please final remark. Then after this, Mr. Tawfiq will come and announce.
No, sure. Dr. Raman, thank you for this wonderful moderation, and thanks to Dr. Arif, Dr. Meki, and Dr. Vivek for this wonderful presentations. Your panel actually has brought up so many questions. I can't tell you which we are not doing full justice to it. Probably we'll have just a session again, and or give your email IDs to our audiences so they can delegates can answer you directly, ask you directly.
Pediatric neurology.
We have to. Yeah.
Now, I would like to request viewers, Mr. Tawfiq will give announcement regarding the raffle.
Yeah, good afternoon, viewers. So, like, we are planning to do the one raffle before the lunch session, but as many of the people have not visited the exhibition booths, so I don't have many entries in the raffle draw still. So I request all of you during the break time to go to the exhibition area and visit the stalls there. So there are some raffle questions, just answer them, then you will be able to enter into the raffle draw.
Mr. Tawfiq, we have kept
double the prices after.
No, we have. I think we have kept the delegates very busy and just stuck to
Yes,
their
yes,
seats.
definitely.
So when will they visit?
They couldn't go out at all. So they
Yes,
were
absolutely.
busy. So now, like, to go to exhibition area, just click on the left and top, like there is a menu button. On that you can click exhibition. Then you will be going to the exhibition area. There are different 12 stalls. Just click on the raffle question there and answer it. Then you will be entering the raffle draw. So we will do one thing. So we will have one raffle draw before the afternoon session starts, sharp at 1:45. Then we will have two final draws at the end of this afternoon session. So let's see, we will welcome you back again at 1:45 before we start the afternoon session.
One announcement. At the end of this conference, I will announce the name of the most senior active members of Dubai Pediatric Club, and in a special ceremony, we will felicitate them, give them certificate and token of appreciation. So stay tuned with us till the end of this conference.
And the afternoon session is going to be really interesting and fun session. So we would urge all of you to log in again in the afternoon. Thank you.
So we'll come back at 1:45. Thank you very much for all the viewers.
Thank you. Thank you.
Thank you, neurology panel. Thank you.